A warm good evening to each and every one of
Morning.
you.
Hello. Good morning.
And for here in India, and good morning in United States and in Mexico. Uh, it's indeed a prestigious moment for ISMSICS Society, founded by our founder chairman, Dr. Sahu and Dr. Boromani, that we have an installation of the US, United States, and the Mexico chapter of ISMSICS. Without wasting much time, who doesn't know about the United States and the Mexico? But just one point, if we can really stretch upon it, is it's only the 4.2% of the world total population, but it holds the 29 to 30% of the total wealth in the world. And that itself says that it's the largest share held by any country. And it is home to some of the best musical artists of all time, including the Frank Sinatra, Elvis Presley, Jimi Hendrix, Madonna. It just goes on and on and on. And the motto of the USA is, "In God we trust." So with this, we have our founder chairman, Dr. Amulya Sahu sir, to please give his opening remarks for this prestigious moment for Indians and Americans and Mexicans as well. Over to Dr. Sahu sir. Sir, you are muted.
A very good morning to all of you. It is an important day for ISMSICS. We are installing the USA and the Mexico chapter. And my dear friend Boni's dream has come true. We have been thinking about it for so many years now. So finally it has taken shape and it gives a lot of happiness. And thanks to Pamela for her initiative and help. So now I welcome USA chapter Joseph Miller, Dr. Julian Jeff Lisa Ray, and Dr. Sarah Merrill, and Sujan. Sujan should have been there first. So now she has come, that's a good thing. And Mexican chapter, I know I have met Jaime and Pamela and the other people. I welcome you all, and they are going to be introduced by our moderators. So it's a good thing. And two things I want to say, that after this chapter formation, every month there should be a meeting of people, and there should be membership drive. We want to give free membership to all the foreigners for 6 months. And then there should be some kind of academic discussion. One suggestion is there, we should have a multi-centric comparative study between FACO and SICS. And that result will encourage everybody abroad to follow this art of cataract surgery. With that suggestion, I hand over to the moderator to conduct the session.
Thank you, Sahu sir, for those brief words. I now request our executive chairman, Dr. Jagannath Boramani sir, who was one of the first few to start the topical SICS in India. I request Dr. Boramani sir to please go ahead with his presentation for a few minutes. Sir, you are muted. Sir, we are seeing your slides. Just need to unmute yourself.
Yeah, can you hear me now?
Yeah.
Yes, sir.
Okay.
Yes, we can hear you, Dr.
Yeah. Now I'll share it again. I think the screen sharing had stopped. Yeah, you can see it again, no?
Yeah.
Yes, yes.
Yeah. Good morning and good evening to all. Let me welcome all of you to ISMSICS and this event of installation of US and Mexican chapter. ISMSICS is a global organization formed way back in 2005 with our founder chairman Dr. Amulya Sahu with myself, with the sole motto of making the art of SICS popular across the globe. As on today, we have around 2,000 life members of ISMSICS. This is the installation, the launching of the ISMSICS in a small meeting in Mumbai. This was the SICS meeting in 2005. Immediately following the meeting, ISMSICS organized various international events. The first conference was in China in 2005 itself. Subsequently, there was a big 3 days SICS event in Kuala Lumpur, Malaysia. This was followed by the Indonesian conference. Their annual conference of the Peridami was held under the aegis of ISMSICS in 2008. In 2009, we had a conference in Egypt, followed by conferences in Sweden and Philippines. In 2013, we had a live workshop, SICS camp, as well as a small conference in South Africa. In 2015, ISMSICS surgeons conducted a wet lab in APACRS. I was the editor of the ISMSICS and had published almost 7 journals of ISMSICS. Now, very soon, the new journal will be launched under a new editorship. We started holding our annual biennial conferences, the world conferences. The first was held in Pune in Maharashtra, in India in 2015. This was a 3 days event. This was followed by the next conference, the second biennial conference in Chennai. This was held jointly with Arvind Eye Care Systems. Then in the same conference, we had a tie-up with Help Me See, who are into the SICS simulator trainings. In the WOC 2018, ISMSICS surgeons conducted a wet lab, and in the same conference, our ebook, The Master's Guide of SICS, was launched at the hands of Professor Rafael Bereker. We had multiple CMEs in India under the aegis of ISMSICS, and ISMSICS was invited as a part of multiple conferences in India. The All India conferences also regularly used to give us symposia in the annual conferences. This was our last world conference, the third biennial world conference held in Kolkata. This was a big 3-day event under the directorship of Dr. Devashish Bhattacharya. In the last virtual WOC also, the AIS had a symposium, and the one session was given totally to the ISMSICS surgeons, and the session was an SICS session. In the last biennial world conference, a midterm conference was announced in Bangkok, but because of the pandemic, it had to be cancelled. Our next biennial world conference will be very soon in September 2021 in Chandigarh. Dr. Bonnie Henderson announced the 2023, the 5th biennial world conference in US, but will be shifting it to 2025. And the 2023 conference will be taken by LV Prasad Eye Institute in India. We have presence in multiple states, almost all states in India, and we have affiliations with multiple organizations. And we have a lot of future plans. These are the glimpses of our physical launching outside India. One was in Egypt, one was in Bangladesh. And in the pandemic, we held multiple webinars. The attendance also was massive across the globe. So with this small introduction, I request everyone to become a member of ISMSICS. The membership will be free for non-Indians for almost 6 months. So for the details, you can contact us. Thank you very much.
Thank you, Dr. Boramani, sir, for giving the glimpse about the ISMSICS Society, which I think we are having the installation of the US and the Mexico chapter. And I would like to welcome Dr. Pamela as well. She's one of the backbone and the main reason for forming this both chapters. Without wasting much time, we'll go ahead with the installation ceremony. First, we'll be installing the office bearers from the United States, and then followed by the office bearers from Mexico, and then we will go ahead with the talks and the presentation. It'll be just a few minutes of installation ceremony. I'll be just sharing my screen. I hope the screen is visible.
Yes.
Yes.
Yeah.
Yes, it's visible. Thank you.
Thank you. Okay. Is it coming in the slideshow mode?
No, not yet.
Make it full screen.
Yes, sir. I'll just stop it and come back again. Sorry. Rohit, can you help me? It's not getting in the full screen mode.
Try pressing F5.
1 second, sir. I did that.
I would go ahead and actually start the screen for you so that you can just go.
Yeah, just a second. I'll give one more try last. I'll just open it.
Try pressing F5 instead of that icon. Just see.
Yes. Is it seen now?
Not yet.
Yeah,
Still in the regular mode. Still in the regular mode. We can just do the screen for you. Sir.
I think Jagdish, you can go ahead. I will just.
Okay, sir. Just stop sharing. I can go ahead.
Jagdish, can you stop sharing?
Okay.
Go in the slideshow mode, please. Okay. So, ladies and gentlemen, here we have with us today Dr. Joseph M. Miller, the professor and head of ophthalmology and vision sciences, completed his residency from Yale University and pediatric fellowships from the prestigious Johns Hopkins, developed various instruments in screening children for eye diseases. He's on the editorial board for Survey of Ophthalmology, Journal of Ophthalmology, editorial reviews. So it's a proud moment that we install him as the chairman of the US chapter of, and here comes the virtual bouquet presented by Dr. Amulya Sahu. And then we have next. Thank you very much, Dr. Joseph. It's been a pleasure. And do you want to say something, Mr. Joe?
I would just like to say what a pleasure it is to be a member of this organization. Help participate and promulgate this technology. Thank you for the invitation, and I look forward to working with everyone and making new friends.
Thank you so much, and welcome to the ISMSICS family. And next we have another dynamic lady, Dr. Jillian Wong, who is the clinical assistant professor of ophthalmology from University of Arizona, is the medical school from Ohio State University. So it's a proud moment to install her as the vice chairman of the ISMSICS Society. And here comes the medal from Dr. Boramani with the virtual bouquet. Thank you, Dr. Jillian. You want to say a quick few words?
Thank you so much. I really appreciate the invitation to this society. And I had the chance to work with Dr. Pamela a couple years ago, learning some more techniques. So I'd love to incorporate that into my practice. Thanks so much.
Thank you. And here comes the ever-smiling lady, who is none other than Dr. Bonnie Henderson. Is the clinical professor at Tufts University School of Medicine, the past president of the American Society of the Cataract and the Refractive Surgery, associate editor for the Journal of Refractive Surgery and Eye World, published 5 textbooks in cataract and refractive surgery, and authored more than 175 papers, books, and chapters. So it's a proud moment to install her as the president of the ISMSICS Society of United States. And here comes the virtual bouquet from Dr. Amulya Sahu. Welcome, Dr. Bonnie. Welcome to the family. You would like to say a quick few words, Dr. Bonnie?
Sure. Thank you so much. It's such a pleasure and such an honor to be working with you all. And I'm always humbled by all the experienced SICS surgeons in this organization. I really want to say thank you to Dr. Sahu and Dr. Boramani for leading this effort and allowing us newbies to actually join in your organizations to learn along the way. I welcome our fellow Americans. I'm so excited to work with all of you and look forward to a wonderful, successful future for our organization together. Thank you.
Thank you, Dr. Boni. And in fact, it's a proud moment for the US as well. You had the new president, and we Indians are still more honored and proud because we have the Vice President Kamala Harris as the first Indian American Vice President. So it's a kind of the bonding which we are looking for. Thank you very much. And we go ahead with the installation of our Vice Chairman, who is none other than Dr. Lisa Park, the Associate Professor of Ophthalmology at Columbia University Medical Center, pioneered in simulation-based training and has taught more than 70 ophthalmologists, participates in the humanitarian missions to underprivileged areas of the world in Guatemala and Ethiopia, published over 50 book chapters and has published various papers in various journals. So with this, I would like to call upon Dr. Buramani to please honor her with a medal and with the virtual bouquet. Welcome, Dr. Lisa. Any quick comments, please?
Thank you so much. I echo everyone's sentiments. It is truly an honor to be asked and invited to join this organization. And I look forward very much to working with and meeting all of you and advancing this particular cause. Thank you.
So nice.
Thank you. Thank you for those quick words, Dr. Lisa. And here we have, again, a dynamic secretary, Dr. Jeff. Last time we saw Junior Jeff as well in the webinar, and hope he is joining too in the installation ceremony as the secretary of the ISMSICS Society. Dr. Jeff is Associate Professor of Ophthalmology and Visual Sciences, Residency Program Director and Medical Director of Global Outreach at the University of Utah, Department of Ophthalmology and Vision Sciences. He's the Chief of Ophthalmology at Salt Lake City Veterans Affairs Medical Center, published 41 peer-reviewed articles, authored chapters, and reviewer of various journals. His clinical focus towards the posterior traumatic anterior segment surgery. And with this, I request Dr. Sahu and Dr. Pamela to please honor Dr. Jeff with the, here comes the medal, and request Pamela to present the virtual bouquet. Thank you, Dr. Jeff. Dr. Jeff, like to say a quick few comments, please?
I think he's not right now because he wrote me he had some complications to join us, but he's happy to be.
Oh. Okay, no worries. We'll take him later. And then we have a joint secretary, Dr. Sarah Merrill, who's completed her medical school and residency from Georgetown University of Medicine. The primary focus in both traditional and advanced cataract surgical procedures. She's the board member of Loudoun Ambulatory Surgery Center and Northern Virginia Academy of Ophthalmology. I request Dr. Buramani to please present her with a medal, and request Dr. Pamela to please present her the virtual bouquet. Thank you. Thank you, Dr. Sarah. Are you there for quick comments?
I'm not sure she's here, Dr. Joshi. Let me see the screen.
She's from the US joining us, who is none other than Dr. Susan McDonald. Dr. Susan, what do you think about this? You would like to say a quick comments, please?
Give her a flower.
You can unmute yourself, Dr. Susan.
I just want to
She's a special invitee and special guest of honor today.
I want to congratulate everyone on their positions, and I am so delighted to see that we are all working together with a very noble cause, and I am always honored and humbled to see the expertise and the talent of MICS surgeons. I really think it is the one of the best techniques, and you are all experts, and I look forward to learning from you all.
Thank you. Thank you for those kind words, Dr. Susan.
And I am so happy to have Kamala Harris as my vice president, because yes, she is the first Indian president, vice president, but she is also the first woman vice president in the United States. We are moving forward.
United States.
Defeated Trump.
And if you remember, Dr. Susan, in the last debate, if you remember, you were praying for this moment and it happened.
Yes.
If I'm right.
That is right. That is exactly right. So the world is changing. Thank goodness.
Yeah. Okay, great. Great. Thank you so much. And with this, I now request my colleague, the dynamic, what you can say, whatever we are doing now together today is none other than Dr. Jagdish Reddy. I request Dr. Jagdish to please install the members from the Mexico.
Hi, it's my privilege to actually be a part of this momentous occasion where we have actually covered most of the North America, the Mexico and the United States. It was really nice and a warm welcome to all the people of the United States ISMSICS chapter. And now without further ado, I would like to introduce the chairman of the Mexico chapter, ISMSICS, none other than Dr. Jamie, who is the head of the cataract department at the Mexican Institute of Ophthalmology. A great man with a lot of work behind his belt. Welcome, Dr. Jamie. And I would request Dr. Amulya Sahu to hand over the medal and Dr. Bonamani for the bouquet. Dr. Jamie, could you tell in a few words for us, either in Spanish or English? It's fine for us.
Thank you very much for invitation, and I am very happy to belong to Mexico chapter. I recognize the word Sahu and Dr. Baramani. Thank you very much.
All right. Now we are going to introduce our vice chairman, a dynamic young lady, Dr. Teresa Flores, who is also a cataract surgeon at the Mexican Institute of Ophthalmology. Welcome to be part of the ISMSICS Mexico chapter. Welcome to the family. I would request Dr. Pamela to actually give her the bouquet. Welcome, Dr. Teresa. Do you want to say in a few words?
Hi, I'm glad to be here. Thank you for the invitation.
Thank you. Now we go to the president of the ISMSICS, who is the dynamic lady who actually Dr. Sahu, Dr. Boramani, and Dr. Srinivas always keep talking about, without whom this chapter would not have been possible and this conference would not have been taking place. Thank you so much, Dr. Pamela. And she is also a cataract surgeon at the Mexican Institute of Ophthalmology. And it's a privilege, and I would request Dr. Sahu, sir, to know the medal, and Dr. Boramani, sir, for the bouquet. Thank you, Dr. Pamela. Do you want to add in a few words on this occasion, please?
Yes, thanks. Thank you, everybody. It's such a pleasure to be here with such a fine group of surgeons and friends. And thank you, everybody. Thank you for ISMSICS members for being so patient with me these days. Thank you.
Well, smile. Why you have put up a grumpy face here? Yes.
Because she's smiling all the time, sir. That's why she has kept some photographs without smile in the book.
Thank you, Dr. Pamela. And I would request a little help from your side to actually introduce a few other members. I would keep sliding. Go ahead.
Yes, of course.
Yeah.
So the vice president of the ISMSICS chapter is Dr. Sandra de la Cruz. Sandy is a really, really great cataract surgeon at the Mexican Institute of Ophthalmology, and she's also involved in research in the area. So thank you, Sandy, for being here. And I will ask Dr. Sahu to present you with the medal and the bouquet. Just say a few words, please, Sandy.
Hi, good morning, good evening, everybody. Thank you, Pam. It is an honor to be part of this project. And I want to thank everyone for their hard work around the world, and thank you.
Okay, so the secretary of the Mexican chapter is Dr. Omar Gonzalez. Dr. Gonzalez as myself, he's not my brother, but he's also Gonzalez. He's a really, really skilled cataract surgeon at the Mexican Institute of Ophthalmology, and we are really excited because he's going to stay us as an attendant now and help us train residents at the Institute. So I will ask Dr. Boramani to present him with the medal and the bouquet. Welcome, Omar. Would you say a few words?
Hi, thank you for the invitation. It's an honor to be part of this organization. It's full of so many experienced people, so I hope we can learn a lot in this new step. Thank you.
Thank you. So the Joint Secretary for the Mexican chapter is Dr. Sandra Cárdenas. She's also a really skilled cataract surgeon at the Mexican Institute of Ophthalmology. She's a great friend, and we're going to be very happy because she's going to be working in a new hospital here in Querétaro. Welcome, Sandy, and I will ask Dr. Jagadesh to present you with the medal and the bouquet. Would you say some words, Sandy?
Yes, hello. It's a pleasure to be with you all today. Thanks for the invitation. I really think that this meeting is very enriching for everyone. I hope to get the experience of all the experts who are meeting today.
Thank you, Sandy. So the scientific committee members, the Dr. Fabiola de la Peña Guani and Dr. Ileana Herrera, both of them really skilled cataract surgeons. Dr. Fabi Peña, it's a really skilled woman as a cataract surgeon, but also as a businesswoman, so I really admire her. And Dr. Ileana Herrera is now during her cataract training this year, so I'm very happy to have both of you here. Thank you for being here. And I'll ask Dr. Sahu to present both of you with the medal and the bouquet. Would you like to say some words?
Hello, everybody. I am really happy to join with you and being part of this great project. Thank you very much.
Thank you for being here, Fabi. I think Ile is not here at the meeting. And the executive committee members of the ISMSICS Mexican chapter, Dr. Eder Valencia and Dr. Maria Jose Montero. So Dr. Valencia is a really skilled cataract, retina, and vitreous surgeon. I'm really happy to have him here with us. Even though he's not now at the Institute, he's doing a great job at the north part of the country. And Dr. Maria Jose Montero, she's a really good friend, and she's part of an excellent program, she's head of the teaching program at the Orbis department. So she's actually in charge of the Orbis Flying Eye Hospital. She's been in so many countries teaching M6 all around the world. So it's an honor to have her here. So I will ask Dr. Boramani to present both of them with the medal and the bouquet. And I will ask both of them to say a few words, please.
Hello, everybody. Hi. I'm sorry for the video. Thank you for the invitation. I hope the best experience with us. Congratulations for us.
Thank you.
Hi, everybody. Good morning, good evening. It's an honor to be part of this wonderful organization and society with all of you amazing colleagues, as I truly believe that small incision cataract surgery is a technique that every ophthalmologist should have in their pocket. So thank you very much.
Very good.
Thank you, Dr. Pamela, for that, helping me out in the introduction of all those great members. And it was, I think, very refreshing, and everyone would have woken up by now with all those claps. It's an early morning for all of you out there, I know that for sure. And it's really lively seeing you all over here. And without further ado, we'll just go ahead. Thank you so much for all the people from the United States and Mexico for making this happen. And to continue with our presentations, the first would be the topic about refining MSICS, and it's presented by Dr. M.S. Ravindra, who is none other than the head of Karthik Netralaya. I hereby request Dr. M.S. Ravindra, sir, to start his presentation.
So everybody must stay for the discussion, participate in the discussion. Jagdish?
Sure, sir, sure. Sir. I'll make it.
Everybody to participate. Rabindra is one of our outstanding SICS surgeon, a teacher par excellence. So whatever he's going to say, we have to, there will be a few points we can take home.
Ravindra sir conducts a weekly seminar on M6 every week with new updates and very challenging tips. If you're a part of a group, we would be happy, once we form a group on the WhatsApp, we would be happy to actually forward all those wonderful sessions to you. I would request all the people from the US and Mexico form chapters on a WhatsApp group so that we could forward the excellent videos of Dr. Ravindra sir.
Good morning and good evening. Am I audible, Dr. Reddy?
Yes, sir. Fine. Loud and clear, sir.
Fine. The video is visible if I'm right.
It's not playing as of now. Yes, sir. We can see it. Yeah, right now, yes, perfect.
Yeah. Good morning and good evening to everybody. And I congratulate everybody who is concerned with this development of creating an organization in Mexico as well as United States of America. So, in this short period, I'll show a couple of videos which will tell us where we can proceed from the basic SICS to the advanced SICS. Everyone is scared of posterior polar as well as posterior subcapsular cataracts, but in SICS, it's going to be very, very easy and gentle on the eye. I'm doing the rhexis. The incision is 2.8 millimeter. It comes from the scleral, anterior sclera, traverses across the limbus and ends in the cornea. And I have punctured the floor of the tunnel to enter into the chamber so that there's no loss of chamber during the rhexis. And with a special cannula, I'm opening up the space between the capsule and the cortex and inject a slight amount of fluid so that the fluid spreads along the equator. Then I turn the cannula downward so that this is directed towards the equator, then inject a very small quantity, and I do a segmental capsular separating hydrodissection even in posterior polar cataract. This is possible only when you have a shallow anterior chamber and a low pressure, and the visco in the anterior chamber is removed. It's a soft nucleus and epinucleus. It's not separated by a hydrodelineation, and it comes into the anterior chamber, and then it's bisected with an infusing cannula. This is a 25 gauge cannula which is continuously injecting viscoelastic, and the entire nucleus and heminucleus are aspirated out of the, guided out of the eye. The endothelium is maximally protected because the gliding nucleus is separated from the endothelium with the viscoelastic. You can see the posterior, the plug of the subcapsular cataract, you can see there. Because you've done a hydrodissection, there's not much of effort that's needed to separate the cortex from the capsular bag. And as you can see, easily it comes out. The chamber is not deepened. Entire surgery is done under low pressure. It's basically anywhere between the atmospheric pressure and the normal intraocular pressure. At no point of time, except during the rhexis, the pressure is higher. The posterior capsule is not pushed backwards and stretched because it's attached through the zonules to the scleral spur, the sclera, and now you put the lens, and that's the end of surgery. So there are no side posts needed for this technique at all. One main tunnel is good enough. So this is a slow motion. I'll just show you how I go. I'm not injecting anything. With the tip of the hydrodissection cannula, I'm entering between the cortical fibers and the capsule. As you can see here, I'm proceeding towards manually separating the capsule from the cortex. Inject a very small amount of fluid so that it traverses along the circumference of the capsular bag. Then I've done the segmental capsular separating hydrodissection. That is done after coaxially rotating the cannula. So you can see the fluid wave that's going and separating the posterior capsule from the cortex. So we'll go to the next video. This continues. What about a posterior polar cataract? Something like this. It's a classical onion rings with radiating folds and dots. You can do the similar procedure even in this technique. Much of the scare that we have with posterior polar and posterior, subcapsular cataract is we are scared of the blasting of the posterior capsule, so we are very careful in not doing a hydrodissection. But if you do a hydrodissection, as you see here, and then that's under topical, I'm running it fast, same technique, segmental hydrodissection, then hydrodelineation is the soft cataract, rotate it. It's not coming out into the anterior chamber because of its softness. I've done a hydrodelineation, then through the little larger tunnel that you have created here, the entire material can be prolapsed out. As you can see here, the plug has come out. The plug which occupies the center of the ring in the posterior cortical has come out. It's coming out of this. Then you aspirate the cortex. It's very easy because of your done hydrodissection. There is no traction on the posterior capsule. And that's the end of it. Then you can put a lens there. But what is the phacoemulsification machine I'm using? That's a machine. The entire thing is a Simcoe cannula attached to a silicon bulb and a syringe which aspirates. It provides every function that an elegant phacoemulsifier provides, and that should be a 5 ml syringe which I hold in the left hand and control the aspiration. Because I don't have a side port, I need to have a sub right and left reverse Simcoe cannula. The BSS is loaded into that, and the infusion as well as the aspiration both are under excellent control. That's what the modern phacoemulsification does. How do I inject a lens? Because it's a little larger one, I cannot push the lens directly. I always slit the cartridge on the top of it, load the lens into it's a very elegant procedure. You don't need an injector at all. That's a lens which is loaded into the cartridge, fold it conventionally after dipping it in viscoelastic, HPMC, then push it to the front. And what happens is you can push it with a rod, the engaged rod. You don't need an injector. And hold the cartridge in the left hand, push it. You can see the slit opening, and that minimally, that does not damage the lens at all as it's being injected. It's a very simple procedure. What about a soft nucleus? This is a case with IFIS and very soft nucleus, small pupil, about 3 to 4 millimeters. You do a good hydrodissection, rotate the nucleus and epinucleus together. Do not try to separate them. Nucleus is easy to remove, cortex is easy to remove, epinucleus is always tough. You don't need a mydriatic device to do an SICS as you see here. Inject viscoelastic and guide it out of the eye. What about a high myope? Like this is bisected and removed it. There are a couple of ways of minimizing the size of it. This is a very high myope who needed a -1 diopter lens in the bag. So now the same technique, prolapse it, do not separate the nucleus and epinucleus, bisect it and remove it from the eye. Take it fast forward. The length that's needed is -3 diopters. There is a device called snare. As you can see here, there's a very large cataract. I prolapsed into the anterior chamber. We need to bisect it. One of our close friends has devised this bisector, Dr. Anil Shah, and you can divide it. Any hard cataract, rocky cataract, wood-like cataract, or anything can be bisected easily. And you'll have to protect the endothelium by continuously injecting viscoelastic. As you can see now, it gets bisected easily. And then each piece can be removed from the eye by various techniques, as you can see here. Continuous infusion of viscoelastic protects the endothelium, and you can put a lens inside the eye. There is another very elegant way of putting a lens there. There is no posterior capsular support in this particular surgery, and there is enough space to put a PMMA iris claw lens, take it behind the iris, and enclavate into the iris. Of course, it gets attached to the iris. Iris is attached to the scleral spur and sclera. That's an indirect scleral insertion, but it's a very quick procedure. As you can see here, implant it behind the iris, enclavate into the iris, and that's the end of surgery. It takes hardly 3 or 4 minutes time, and that's the end of my presentation. What I would like to convey is it's a very simple procedure, and it's done by our own hands. Very few instruments are necessary, and for mass surgeries, it's wonderful. You can sterilize all the instruments very quickly, and very complex surgeries, in many of Indian hospitals, this is the technique of priority. Thank you.
Thank you, Dr. Ravindra, sir. Such an elegant surgery, amazing, amazing it was. Very nice, and the way you got the iris enclavated, it was also very amazing. So thank you so much. Would request Dr. Joe Miller to actually add in a few comments about this.
I'd like to thank you and compliment you on wonderful videos that illustrated your techniques very nicely. I had no trouble seeing the discussion that you were presenting. I had a great surprise in seeing the silicon bulb. And when I saw that for the first time, I wondered, why in the world haven't we been using that? And I must admit, I must not be keeping up because it's obvious and it's brilliant. Could you tell us a little more about how this silicon bulb was introduced and whether there are special techniques that you have to use in order to keep it from being filled with air bubbles? And what types of technique modification do you use with this silicon bulb? And most importantly, is it reusable and do you have to find a local supplier for it? But thank you, sir. It was a brilliant presentation. It's so much so fast, but the part that stuck in my head first was how brilliant the silicon bulb was for fine aspiration control.
Silicon bulb and a silicon Simcoe. It's devised by Dr. Simcoe from the United States of America. It's landed in India from United States actually. And how did I get it? This first time somebody gifted a Simcoe cannula and a silicon bulb to me in one of the international eye camps. He just gave it to me. He didn't know what it was. It's Dr. George Schroeder from Arkansas. He's the one who gifted them. Then I gave it to a couple of companies in India and got them duplicated here, got them made here. But the credit of devising it should go to Dr. Simcoe, SIMCOE. You're all familiar with that name. How do I fill it up? There is a bottle of BSS which runs through an IV cannula into the bulb. And it just needs 2 silicon bulbs to complete the surgery. The volume of the bulb is approximately about 20 to 25 ml. I do not know. Approximately it's about 20-25 ml. So ultimately for the whole surgery, you'll be using about 50 ml. Each set has got 2 silicon bulbs, and my technician fills the bulb with the IV tube that runs from the BSS. And when you hold it like that, upside down, the opening is down, air goes on the top, and when you push it, air doesn't come along with this thing. The advantage of silicon bulb over a continuous running, like a lot of my friends use continuous irrigation from the bottle directly into the eye, where there is no control of how much of fluid that goes into the eye. So here, with the finger pressures, I have a control of input of fluid into the eye. So I can have, with the visual feedback, I can know exactly how much fluid going into the eye. It should not be too much. It should not be too shallow to avoid the surges. And with the left hand, I aspirate the cortex, aspirate the material. So balance between my right hand and left hand does the best to the eye, which is equivalent to the best of the phaco machines available today.
Thank you. And just about the size, is it approximately the size of a large olive, or is it the size of a blood pressure cuff?
It's much smaller than blood pressure cuff. It's smaller than blood pressure cuff. It holds about 20 ml, if I'm right. I've not measured.
Fabulous.
Approximately, it holds about 20-25 ml. So we need about 50 ml of fluid for the surgery. So 2 bulbs are enough to complete the surgery.
I can't wait to try it in a wet lab.
Okay.
That's great. Dr. Bonnie Henderson, do you want to add something onto it?
Sure. I mean, I wish we had more time for all those videos, because each of the videos that you presented really are challenging cases for all of us. And especially the posterior polar, where, we all shake in our boots whenever we try to take out a cataract, regardless of the technique. So, it's really lovely to see the beautiful videos. like I said, I wish we had more time to actually stop each one of those videos and ask you more pointed questions. But thank you for sharing that with us, and it gives us something to aspire to for those who are just learning this procedure, just becoming competent in the procedure.
Yeah, we do have a chance to actually watch all those videos and you could ask them. It's just that we need to form a small group and then we could start sharing our videos over there. It's Dr. Ravindra, sir, as I mentioned, also gives a weekly course which runs, it's a very nice course. So it would be helpful. Okay, without further ado, I would ask Dr. Jamie or Dr. Pamela if they could add some comments onto this.
No, it's really, really great. Thanks for sharing. I really like the technique of doing it by like a totally temporal approach, because that also, well, it's a good approach and it reduces the induction of astigmatism. And I like the way you do like the first incision and they make it a little bit larger with the second knife so you can get it, the hook for getting the cataract out. So my question is, the second knife you introduced, how big is it?
The first one is 2.8 millimeters. The steps are, I make a 2.8 millimeter, like a phaco incision, but it's much posterior. I involve a little bit of conjunctiva, anterior sclera, the entire limbus, and a little cornea. So it's a little longer tunnel when compared to the conventional phaco tunnel. And I start on the scleral side so that it heals very well. It heals absolutely nice. And then I inject viscoelastic into the eye. Then by puncturing the floor of the tunnel with a cystitome, I do rhexis. So the beauty of this tunnel floor entry, I call it, is that the tunnel is sealed when you're doing it, and the needle perforates the floor and gets into the eye. There are a lot of videos on YouTube. You can have a look at it as to how to do it. It's a wonderful technique. And you don't lose the chamber when you're doing rhexis. Then after this, I enlarge it with a 5.1 millimeter enlarger, and that enlarges 2.8 to 5.1. And these blades are available from Mani, M-A-N-I, from Japan. They are very good, and they're also useful to enlarge the phaco wound in case you need to convert your phacoemulsification. It's actually meant for that. These are designed for that, but I use it for the planned SICS in my surgeries. They're very good. Okay, and the amount of astigmatism I get with this is 0.5 to 0.6 diopters, exactly that. But I can titrate it, like Boramani is going to tell us. If I go a little more anteriorly, I can correct up to 1.25. If I want 0, I'll go a little more posteriorly. So from 0 to 1.25, I can control by titrating the length of the tunnel and, more importantly, where I start my tunnel.
Okay, thank you. This is really interesting. Thank you.
Thank you. Thank you, Dr. Ravindra, sir. And
these tunnels do not need hydration to close it, because I have not stretched them, I have not heated them, and there is no need to hydrate them. At the end of it, you just leave it. So form the chamber and leave it, and that will close permanently. By next day, you don't even see the conjunctiva heals in 24 hours. The cells are joined, and you don't see anything.
Thank you, Dr. Ravindra, sir. That's a nice way of ending it. What else we need? If not a phaco machine, to actually have a better astigmatic control. We always talk about phaco machines. We always talk about having less astigmatism in phaco. Now, I would ask our executive chairman of the ISMSICS, Dr. Jagannath Boramani, sir, to actually present a better way to manage astigmatism with M6. Welcome,
Thank you. Thank you, Dr. Jagdish. Can you see me? Can you see the slides? And
Yes,
you can hear me? Yeah.
Yes, sir. Perfect.
Now, it is presumed that the phacoemulsification induces less astigmatism as compared to SICS. All the published literature shows a slightly higher astigmatism with SICS because the phaco incision is always compared to a standard 6 millimeter front incision. So let me start tell you whether MSICS is a better way to manage the astigmatism. So let me start with the two cases. Now this case came to me for a multifocal IOL. The astigmatism was very less, only 0.13. But I am always doing SICS. So without the fear of inducing more astigmatism, I did the SICS. And there is practically no much induced astigmatism in spite of doing an SICS incision. Now let me show another case. This was operated in 21 January, means last month only. She is the mother of my optometrist. She landed up with a very high astigmatism, about 2 diopters. Even the auto ref, auto K and auto manual also are showing 2 diopters of astigmatism. Now this lady has high astigmatism in the other eye, which was operated by phacoemulsification elsewhere. The surgeon told her about the toric oil, but she said she didn't want to. The budget was not very high, and the other eye is having 2 diopters of astigmatism now, and she's wearing spectacles for that. Now for this eye, she came to me, and she's the mother of my optometrist. Of late now in India, we are implanting a new type of multifocal lens. In fact, these are not the multifocal lenses. These are called as the autofocus or radially progressive lenses. So this lens gives a good distant as well as near vision. The depth of focus is very good, but this lens is without any ring halos. So even slight decentration also doesn't matter much. You can put it in diabetic patients also. The results are very good. Last 3 months, we have been implanting these lenses. These have been designed by Indian surgeons, and presently the lenses are manufactured only in India. But I feel these lenses are doing better than the multifocal lenses or the extended depth of focus lenses. So the optometrist knew the result and she insisted for that lens. Unfortunately, a toric lens is not available so far with these lenses. But still, I wanted to do SICS only for her. And without a toric lens, I tried to neutralize the astigmatism and see this result. Topographically, the astigmatism came down to 0.43. And the manual as well as auto K showed only 0.25 post-op astigmatism. So she had 2 diopters of astigmatism, which was practically neutralized. And subjectively, she didn't accept any correction. Even that small cylindrical also was not there, and she landed up with a very good distant and near vision. So this is possible to achieve with SICS. If you want to induce, you can induce. If you don't want to induce, you don't induce. The methodology is very simple. All of us are aware that if you have a straight 6 millimeter incision, generally the induced astigmatism is about 1.25 to 1.5. The purpose of making the incision slightly curved or a frown one is to reduce the astigmatism. So we know that if the ends of the incision are going farther away from the limbus, the astigmatism is reduced. So as a logic, you extend this, make it more and more curved, and try to induce less and less astigmatism. So there are no published literatures about such types of incisions, but you can very well design your own methodology, how your incision will induce astigmatism. Try to make it either curved or straight, depending upon the pre-existing astigmatism. So after doing such cases for almost more than 7-8 years, I have formulated my algorithms. So if I want to neutralize about 1.75 diopters of astigmatism, I keep a straight 7 millimeter incision if the incision is on the superior, if the steep meridian is superior. For lesser and lesser astigmatism, try to reduce the length of the incision. For example, a 5 mm will induce about 0.82 diopters of astigmatism. Make the incision curved, you will induce less astigmatism. Make it more and more curved, and you will practically do not induce any astigmatism. So this way you have to titrate your incision against the pre-existing astigmatism. Temporarily, the incisions are weak in neutralizing or inducing the astigmatism. So even a large 7 millimeter straight incision will induce only about 1 diopters of astigmatism. Make the incision slightly more curved temporarily. So these are very weak in neutralizing or inducing the astigmatisms. So this way I manage my cases, always operate on a steep axis and decide the shape of the incision against as per the pre-existing astigmatism. So I call this as a customized incision. The superior temporal and superior nasal incisions, the behavior is exactly in between the superior and temporal incisions. Now for having a better result, you have to always center the incision. It may be a straight incision or a curved incision, but the incision center should come on the steep meridian so that the vector forces from both the sides are acting equally well on the steep meridian. Now the question is where to sit for the surgery. So whatever may be the pre-existing steep axis, you can always get this half circle in the right eye and the similar another half circle in the left eye. So whatever may be the steep axis, always you can center the incision on the steep axis. And then you can tabulate your results, keeping one type of incision in one table and find out what is your surgically induced astigmatism. Now let me show you a few cases. Now this case again had only very slight astigmatism, 0.28. This is a multifocal lens case. Again, I have slightly neutralized it without inducing much astigmatism. Now this is another case, 1.12 diopter. So this is a 97 is a steep one. I have kept a straight incision here and again neutralized and brought it down to 0.15. This is 0.4 temporal with a curved incision further reduced to 0.09, so on and so forth. Again, temporal 1.24 diopter strip, have a little bigger straight incision and neutralize it. Now this is an interesting, again a case of very high astigmatism, 3.49. This patient was not affording a toric IOL. So budget also was not there, but I tried to minimize it and brought it down to 0.64. So here I neutralized almost 2.98 diopters of astigmatism. This is a straight 7.5 mm straight incision. For that case, I could have gone for a little bigger incision and neutralized that astigmatism also. This is another case of similar case, high astigmatism 3.3, which has been brought down to 0.56. So you can sell it as a premium surgery without putting a premium lens. And you can charge more to the patient for your customization of the incisions. This is a multifocal, almost no change in the astigmatism. This is another case, multifocal lens implanted in a doctor case where again astigmatism was 1.97, but I didn't go for a toric and neutralize it. The astigmatism brought down to 0.15 only. This was with a superonasal incision. This is on 165 meridian, straight incision, superonasal in the left eye. So this is slightly difficult to operate because nose is coming in the way here. And this patient also is enjoying a perfect vision without any glasses. This is a multifocal lens without any, but no toric IOL. So now I don't call this as a surgically induced astigmatism. I call it as a surgically corrected astigmatism. And the surgery also is a, instead of small incision, I call it as a customized incision cataract surgery. So all of us are aware that when the patient lies down on the table, there is some cyclic rotation of the eyeball. So like you do in the toric cases, always mark your horizontal and vertical meridian in the patient sitting position. Then only you proceed and mark your steep meridian on the table again and try to center your incision on the steep meridian. So the marking can be only on one side. You need not mark the other side because this is not a toric IOL case. Here now the steep axis is 39. The incision is a straight one. So I'm trying to keep this steep meridian on the center of the incision. This is a curved incision, 70 degrees is the steep meridian. So this way you can proceed and try to get a good result. Now, the people who are learning the SICS, who are the beginners, they should not venture into such techniques because they should first protect the endothelium. Don't try to venture for a hard cataract and try to take out through a small incision. Now here, this is a very small incision, 4 mm incision, U-shaped incision, because I don't want to induce. I'll just show you one method how I manage the nucleus in such cases. This is again a case of hard cases, hard cataract. I operate with a AC maintainer. All the cases are done under topical anesthesia. This is less than 4 minutes. In fact, you need not go less than 4 minutes, even if 4.5 a U-shaped incision, there is no induced astigmatism. So when the nucleus gets stuck into the scleral tunnel, I always pass a Sinski hook through a side port. There is always a side port on the right side. The chamber is full because of the entry chamber maintainer and try to push the nucleus. So either the nucleus gets fragmented into the scleral tunnel or it stretches the scleral tunnel and comes out. This technique I call it as an endo expression of the nucleus. So this is very helpful because all the pressure is borne by the walls of the scleral tunnel and not the endothelium. So you are quite safe, and I'm operating with the AC maintainer. But this can be done with visco also. Those who are not using AC maintainer, with viscoelastic, under viscoelastics also you can do. So the advantage of this technique is that now consider there are two cases with 2 diopters of astigmatism. I want to neutralize 2 diopters. I employ the same method for both the cases. But suppose there is undercorrection in one case, because there can be some variations. And undercorrection means you are neutralizing only 1.5 diopters in this case. So patient lands up with plus 0.5 diopters of astigmatism. Similar second case, but there is overcorrection. Now with the overcorrection, there is neutralization of 2.5 diopters, but still the patient lands up only with 0.5 diopters of astigmatism. So in spite of a range of error of almost 1 diopter, you are always on either plus or minus side of the zero with the change in the meridian. That is the beauty of this procedure. Thank you very much.
Thank you. Thank you, sir. That was a wonderful presentation. We have actually learned a lot of new words, surgically corrected astigmatism, customized incision cataract surgery, and the endo expression of the nucleus. Beautiful, beautiful surgeries out there. Thank you so much for sharing those wonderful videos. I would ask Dr. Susan to actually comment on this. Dr. Susan.
Please unmute yourself.
just me and my family listening to me here. I have to say that was such a brilliant presentation and so incredibly important to distinguish between phaco emulsification and SICS surgery. We always talk about astigmatism, and that's the real advantage of small incision surgery. And so the idea that there's one is better than the other because of the technology is incorrect. It's just approaching the absolute challenge of dealing with the astigmatism. And I congratulate you because this presentation shows how equivalent or superior SICS can be by just being thoughtful and using the brilliant formulas that you have presented to really customize for your patient. And it really elevates the post-operative refraction to be one that is equivalent. And I really appreciate the brilliance and thank you for sharing it.
Thank you. Thank you. Thank you very much.
Thank you, Dr. Susan. I would request Dr. Maria Montero to actually add a few words on this.
Yes, I'm truly in awe of these techniques. The last videos and these videos, they are amazing, and they truly show that small incision cataract surgery has nothing to ask for phaco emulsification, and that these cases can be very well solved and treated and give the patient a very high satisfaction rate without the cost of the machines and with the endothelium being very well taken care of. So I'm like amazed. Excellent techniques. Thank you very much for sharing.
Thank you. Thank you for your beautiful comments. And if Dr. Teresa wants to add a few words onto this. Dr. Wang, please.
We couldn't understand who you were asking. So
Dr. Teresa Flores.
Okay, thank you. Yes, I think it was excellent technique. I'm used to teach our residents and fellows, and I think it was an amazing way to show them that how to correct astigmatism. And as Dr. Maria said, I think that it's a technique that you can have the same results as the phaco emulsification. Thank you, Dr. Baramani. It was a great presentation.
Thank you. Dr. Miller, do you want to add something onto this beautiful presentation?
It was very interesting to see how one can adapt their surgical position to virtually any position that's required by the surgery. I am in awe that someone can do supratemporal incisions with small incision cataract surgery, just trying to rotate to the appropriate angle under any condition as a surgical challenge that needs to be addressed is something that not many of us would have the skill to do in their beginning years. So I appreciate greatly the disclaimer that you put in your presentation. Don't try this until you have a lot of experience. I think that's appropriate to have in a presentation such as this.
Thank you. Dr. Jamie, do you want to comment on this? Dr. Jamie Martinez,
I know the confusion right now. It's it's Dr. Jaime in Spanish. That's why we were not understanding until I realized
Dr. Martinez. I think the better way I would say is Dr. Martinez. I'm sorry for that.
No, it's perfect. It's perfect. And I want to apologize for him because he just wrote me he had to go offline for a few minutes. But sorry, that's what you were saying, Jamie. And I was, okay, I think there's no Jamie in here, but sorry.
Okay, it's J is H as in you. So sorry.
No, it's perfect. It's perfect.
And, Dr. Wang, do you want to comment anything on this?
Sure. I mean, that was a very, very impressive presentation. Absolutely. I actually I graduated in 2018, and so we're really trained purely in phacoemulsification. So I actually wasn't even aware that you could titrate and customize the astigmatism correction with small incision cataract surgery. So that was very incredible to watch.
Thank you. That's a new thing. That's probably your next thing on the agenda for an SICS. We do actually have SICS courses coming up online with all the information available probably in the next 2 to 3 months for all the available for all the ISMSICS members actually. Initially, we would actually come out with a flyer and actually would have more information on that. Towards the end of the talk, probably I would actually even brief you about that. And thank you so much for those comments. Without further ado,
can I have one comment, Dr. Jagdish?
Yeah, please, Dr. Goramani.
I just want to have one comment just to tell my confidence about this technique. I am having a phacoemulsification machine with me, which is not a high-end machine, but I can proudly say that about 5 years back, I totally stopped doing phacoemulsification. If some patient forces me to do phacoemulsification, I'll always carry some guilt feeling that I'm doing some amount of injustice to the patient. So I market my technique as a customized technique, and I charge more than all the phacosurgeons who are sitting around me. Thank you very much.
Thank you. Thank you. That's great. That's really great to hear.
Wow.
Anyone? Okay. Without further ado, we'll go ahead with the next session by none other than the president of the USA chapter. The topic for the day is what not to do when performing MERIDIAN. And I hand over to Dr. Bonnie Henderson for the.
Great. Thank you very much. I will start to share my screen. And okay, can you see that? Can you see my screen?
Yes, please go.
Great. So I'm so glad I'm following that beautiful presentation. And the reason is because, you know, when we oftentimes go to meetings, we tend to watch these beautiful videos from all these experts. And sometimes when we learn how to do these procedures, it's not so beautiful. So I just wanted to show actually my first case that I did on my own after I trained, and I came back to Boston and I thought, okay, I think I got this, I can do this. And I just want to show what it's like to actually learn how to do this and share some of the mistakes that I made so that other people can actually learn from my mistakes. Okay, so, all right. So when I wanted to learn how to do manual small incision surgery, I traveled to India, of course, which is really the mecca of these innovations. And under the very patient tutelage of Dr. Haripriya Aravind, she was kind enough to hold my hand and take me through this. And I spent a few weeks with her and saw the beautiful surgery that she did and her colleagues did. And then I learned how to do the procedure with her by my side. And as you can tell, this was quite a few years ago. Her beautiful children are now grown, and I think the oldest daughter is now in her 20s. So it's been a little while since she patiently taught me how to do this. So I thought, you know, okay, I think I got this. I learned how to do this, and I went back to Boston to do my own surgery. So I wanted to show you a couple videos of what, you know, in my mind, I thought I was ready for. So first I'm going to play this. I hope you can hear this. So that's in my mind, I'm thinking I'm going to be this accomplished surgeon. It's going to be beautiful, melodic, everything's going to go smoothly. And this is really what happened. So that's actually more the reality. So people tend to, you know, you have to learn to walk before you can run. So I just want to share some of my dirty laundry with you. Okay, so, you know, there is a learning curve, and, you know, I'm an experienced phacosurgeon, right? That's what we learn in the US. That I've been doing this for years. I'm also an experienced large incision extracap surgeon. So I started in ophthalmology, I think it's 28 years ago now. So when I trained in residency, we actually learned how to do large incision extra cap surgery. So I knew how to do an extra cap. I manipulate the conch and make the scleral incision. It's something that I'm very comfortable with. So I thought, the small incision is similar. So hopefully it won't be a big transition. It should be okay. And so I thought it was going to be pretty smooth. So let me just share you the video. And obviously it's been sped up just in interest of time. So I, selected this case. It's a pretty big brunescent cataract. And, I'm taking down the conch, and I thought, well, I don't have to make a large peritomy, which is wonderful since it's a small incision, and do some cautery. And you can tell from the eye that the pupil isn't the largest pupil, but it seems pretty relatively okay. I learned from all the surgeons that this frown technique will minimize the astigmatism. So I made my frown incision. And so I'm making this incision. I even made it quite long. So as you can see, it's close to 6.5, 7 millimeters, just so that I can give myself some nice big working room. I don't have to try to squeeze it through like that very small U-shaped incision that you saw really for the experts. So I'm going to make myself a large incision. I thought I had crafted a good enough tunnel that it wouldn't be too shallow. It's got a pretty dense cataract, so I'm going to stain it with vision blue to try to highlight the capsule to make it easier. And I had learned how to do the can opener style when I was in residency for the large incision, but I learned that you don't need to do that. You can do a capsule rhexis, and I'm comfortable with a continuous capsule rhexis with my phacoemulsification. So I figured, okay, so I'll just stick with what I know. I'm comfortable doing the CCC. So I went ahead and did the CCC, but as you can tell, the pupil, again, is not the largest pupil. And here I am manipulating it, and I'm making the pupil even smaller. So as you can see from the viscoelastic coming out, clearly my incision was not the best crafted incision. And as I'm trying to hydrodissect, I'm making the iris even smaller by touching the iris, which you should never do. I've made the rhexis as large as possible based on the size of the pupil, but now I'm really struggling. So I'm trying to hydrodissect, and you saw Ravindra do this beautiful prolapse of the nucleus with just a very easy hydrodissection. Here I am, I'm struggling. I even put in a cystotome to see if I can use this sharp needle to try to coax that nucleus out. So I'm trying to move it around. I'm trying to pick it up. I put in more viscoelastic. I use more BSS to try to prolapse by hydrodissecting. I'm just not getting anywhere. So here I am just trying to physically just pull it out. So I thought, oh, maybe I'll just use the irrigating vectis. So I don't know what I'm thinking. The lens is not even prolapsed in the anterior chamber. Why I think I can get it up and out, I have no idea. So now I'm thinking, okay, well, maybe I'll just use the bimanual technique. I'll use the other instrument through the side port incision. And that didn't work. So I went back to phaco. I said, okay, I know how to do phaco. I'm just going to use my phacoemulsification to see if I can bury the tip to hold it like a lollipop, and then see if I could prolapse it up. So I'm going to eat up a little of the nucleus to cut down the size of the big, bulky brunescent cataract. I'm going to try to hold onto it with vacuum and try to rotate it out. I'm using my second instrument to try to help me. I'm almost there, but the rhexis is obviously too small, and it's capturing the lens nucleus and not letting me prolapse it up. So I've put in more viscoelastic. At this point, I think I've used my 1 month supply of viscoelastic on this case, and I'm trying to dial it out. It's the rhexis size is just fighting me, and it just won't come out. And of course, I'm not skilled at this, so I don't know how aggressive to be. So finally, I get it out. It's prolapsed up. Okay, I think this is good. So I put in my irrigating vectis, and I'm struggling. Oh, look, now I've prolapsed the iris because clearly the architecture of my incision was too shallow, and the size is way too small. So I'm going to go ahead and increase the size. So I think, okay, now I think I have it. Nope, I'm still prolapsing the iris. So I'm gently putting the iris back in. I made the incision larger. I'm trying to get it out. I'm thinking, oh, my corneal endothelium is probably screaming at me, yelling at me to stop doing this. But I finally am able to get it out. I'm worried that I've broken capsule, so I'm just going to take some scissors and make sure that I cut any vitreous if I prolapse the out. Fortunately, I didn't break capsule and I was able to get the lens out. I've really just macerated the superior iris and it just was not a very smooth technique. So I still remember that case and I was thinking, oh my gosh, I probably just should have phacoed it. But again, I just wanted to share some of the mistakes that I've made. And, when I look back, there are certain things that are really, really important as you learn how to do this procedure. The first is the wound construction really is important to make sure that it's far enough away from the limbus, make the tunnel long enough, make the tunnel wide enough to make sure you can prolapse that lens out. If you're working with a small pupil, I think if you're skilled, you can work with that small pupil as you saw in the previous video, but at the beginning, I think it's a good idea to go ahead and dilate the iris with some hooks. I do sometimes caution that if you leave the hooks or the ring in place, it's sometimes hard to prolapse that lens out. So I wouldn't use something like a Malayugan ring. Instead, I would use the hooks to really dilate the pupil. And then once you've been able to make a large capsule opening, maybe release the hooks so that you can actually prolapse that lens out and above the hooks. And then the large capsule opening, I think, is really, really important. And I think if you are able to master these few extra factors, then hopefully you can become a competent manual small incision cataract surgeon. And then you could be a master like Buccelli, like Dr. Gonzalez, and Dr. Saho. So thank you very much.
Thanks. It's a wonderful presentation for those who are starting with SICS. For your honestly, somebody of your stature, what music you faced, you will really caution everybody. And thanks for your honesty and sincerity in this. And a lot of learning is there.
Thank you.
Same thing happened with me when I learned phaco. I saw doing. I said, why not I do this? I came and tried with the hard, like your cataract. I used my phaco and boom, the lens went down. So that nightmare is still there in the mind.
True. I guess if there's no pain, no gain, as they say, we all have to go through this learning curve.
So when you
Yes.
easy.
Yes, congratulations. It was a great presentation. And I think we have all gone through these cases in M6 and in phaco also. As surgeons, when we are doing techniques, we have all of us have had a case in which we say, okay, why I suggest to this surgery? I just want to close the eye and get somebody else to get this surgery done. But thank you very much. This was really enlightful to all of us. And yes, all of us have had these cases, and in the learning period, it is also very important to see these videos because we can all learn from each other and to see, okay, I can make this detail a little bit like this or a little bit like that. But I think all of us have had these cases. Thank you very much for sharing this.
Thank you, Dr. Henderson. It was really that the masters are actually the cataract surgery, taking those tiny steps, showing from the beginning what the process is. It really helps all those young ophthalmologists to actually go ahead and master the technique, whatever they want to do. And definitely SICS holds a great place in doing it. And probably I would request some comments by Dr. Ravindra sir on this video itself, if he would do something out to help you out at this situation.
No, there's nothing to teach Bonnie. She's masters, and my few inputs here is in SICS of when you do on a hard cataract like this, you need to really have a large rhexis. So doing a large rhexis itself is a problem. As she rightly pointed out, people should not become smaller by any chance. Don't touch the iris is one. And there is another, one of my friend has, there are many ways of doing SICS. There's no single way. So what technique you would like to adopt depends upon your approach to the issue. One of my friend does an oval rhexis as a routine. It's not a round rhexis. Round rhexis has to be really large, and sometimes it's not possible to keep it really large in that way. So he he wets between the small and the big one by creating a rhexis which is oval in shape, which is like the button hole. So it's easy to pass prolapse the nucleus out of the capsular bag. That's a very good way of doing it. Otherwise, you do a large rhexis. If you do end up in a small rhexis, what we routinely do is deepen the chamber and nick one edge. It doesn't have to be round anymore, because now removal of the nucleus and safety of the endothelium are two primary things. Shape of rhexis is secondary to that. Just cut it, and then with the rhexis forceps, you can enlarge it even in one side or two sides or all around, wherever it's possible. Then it becomes very easy. How I learned removal of the nucleus out of capsular bag is exactly the way, in our young days, when a tire of a car gets punctured, the mechanic used to remove the rim out of the tire. So he puts a lever and then lifts it up and rotates it out. It's like a screw coming out of it. So you should have a rotating force and a lifting force. One edge is lifted up, then you rotate it, and then it comes out. It's like unscrewing from a screw from a wooden, and taking it out. Just rotate it. So rotation plus lifting will join. In your case, the rhexis is smaller. All the problems you had is because of that. If I were to be there, I would have stopped it, formed the chamber, aspirate the cortex so that your visibility increases, aspirate the cortex out, loose cortex. Then if the staining has gone away, I would remove the viscoelastic from the anterior chamber, put an air bubble, re-stain and watch the edge of the rhexis, then snip it with vanas. Then with Utrata forceps, I enlarge the rhexis, then I would have tried it out. Otherwise, it's marvelous. So the eye heals so well, and all the mistakes that we have done in the past, today, if you see those eyes, they are bright and shiny. So God does pardon us for a lot of learning errors that we, trail behind us, and that's something we should. And the best would be to do it in presence of a master, a person who is teaching. Like if emulsification is taught, a teacher and a student are next to each other looking at it. Today, the video recording is such a wonderful tool, and once you record a video and put it on one of the groups and get the feedback from others, it's a great learning medium that we have, which we missed in our days. We had to really hunt for a teacher and ask him to stand next to us and teach us. In Orbis, I saw the fantastic teaching mechanism. There's nothing better I've seen how in the West the teachers teach students, but that's something is lacking in our country, which all of you are trying to fill it up by program teaching.
Thank you. Can I ask a quick follow-up question? Do you recommend putting in either iris hooks or a ring to enlarge the pupil if you have a tiny pupil? Let's say the pupil is only 3 millimeters and it won't enlarge on its own.
Bonnie, that's a very good question. I have all kinds of the dilating devices, but I don't need them. In SICS, by and large, you don't need them. The only place where I probably, and I use it once in 2 years, 3 years, I prefer a hook because it can pull the iris, to the periphery. And then it's only role is if you can't do a rhexis, to do rhexis, you may have to dilate the pupil. So apart from that, nuclear management, by and large, the pupillary dilating devices, and even CTRs. I've never used CTRs in my surgery, even in partial subluxation. There's no need for it. So this is only because we are not pressurizing the anterior chamber and pushing the whole lens backwards in SICS as compared to when I'm doing phacoemulsification. So the role of pupillary dilating devices in SICS is very, very less.
Can I come in here?
Yes.
Yes.
Yeah, Dr. Boni, thank you for the wonderful presentation. SICS is not a very easy surgery, and I think this message was given through your talks. Your talks were like watching horror movies. I was watching with heart in my mouth. So it's not a very easy surgery to learn. As far as the pupil dilating device, Dr. Ravindra has rightly said, the need for pupil dilating devices is less in SICS because the nucleus itself acts as a pupil dilator. So at the most, we can use the hooks. But the other devices which are catching on the pupil, like the Malignant ring, these are a hindrance for an SICS surgeon because you have to take the nucleus out into the entry chamber. And I want to ask you one question, Dr. Boni, whether, because so many times we see the situations where how to convert to SICS during a phacoemulsification. You are stuck up with some state and you are converting to SICS case. But do you feel there is any need to convert to phacoemulsification when you have a planned SICS surgery? Any situation where you feel that, oh, I should have straightway done phaco for this case, not SICS?
Not once you've actually learned how to do the SICS. I don't think there's ever a need to convert to phaco. Yes. What you saw in my video was just my desperate attempt.
So this means that this underlines the importance of SICS surgery. So it is for all 100% of the cases.
Agreed.
Could I make a comment?
Sure.
As well? Bonnie, I am such a fan and a dear friend, and I just think what you just accomplished is you made the rest of us feel so much better by just sharing. You know, we've all had these experiences on the learning curve, and I think it's especially hard when you're outside of your residency program to be on a learning curve because there's a lot at stake. And I think you have demonstrated the nobility of humbleness in the practice of medicine, which is critical to being a fine physician. And I really think that humbleness is something that that is a really an important thing, to be a lifelong learner, but also to realize that we are all human and we really need to learn and share with each other, because when we're isolated and when we make each other feel that you need to hide your complications or hide your deficiencies, we create an environment that makes, it doesn't push us all forward. So thank you so much for creating an environment which is learning.
Thank you, Dr. Susan. And I would ask, I mean, with not of a much access of teachers for the M6 in the United States, Dr. Lisa Park, who is actually has some knowledge about these simulation-based courses. Dr. Lisa, would you comment anything about SICS simulation courses, which do you have any experience in that, or it's only about phacoemulsification?
Right. So I want to join Susan in saying, Bonnie, we really appreciated you showing this video. We've all been there. And, you know, it's funny because even right now, I have a patient that I've been really mulling over. I have a 50-year-old who has a brunescent black cataract in one eye after having retinal surgery, which absolutely I've decided to do a 6 procedure on her. And then, but she's a high myope. So the other eye, which has a relatively, you know, soft cataract and is the better seeing eye. And I told her, you're going to need surgery in both eyes. And I generally operate on the worst eye first. And so had planned, I said, well, maybe I'll do phaco, maybe I'll try it. She needs a toric lens. And, and after thinking about it and thinking about it and thinking about it, and finally I went back to her, I said, guess what? We're going to do your best. We're going to phaco the better eye first. And then we'll go back and do 6 on the second eye with my, heart, pumping hard, I'm sure. But I think that she'll have a better outcome. So these are the kinds of decisions that we have to make. And I am also in awe of the fact that to see the videos, the earlier videos that we saw of, really such advanced technique, I think it's really amazing. I do think the challenge in the United States, and especially as somebody who, I'm still very active in teaching residents, and, even the concept to them of doing a larger incision surgery or a manual surgery is something they can't even conceive. And so even having that conversation and introducing that concept when they quickly are able to actually gain the phaco skills relatively easily is something that I think requires, a really deliberate process on our part as educators. And I agree that simulation is something, and being in a very good dry lab or wet lab situation, these are the keys to really being able to teach this technique in a safe manner that's safe, for our trainees, and also what's in the best interest of our patients. And so we're very fortunate. We have the Help Me See simulator. So we're one of two, teaching programs in the US who are now incorporating that into our teaching program. And the advancement of the Help Me See has been really quite amazing in terms of the tactile feedback and the ability to, to approach the surgery from a different aspect. And so I do think these are key aspects of being able to bring this, technique in broad form. It's a funny thing because I, as also as Bonnie mentioned, she started from, and I did also, with large incision surgery or ECCE from the beginning, and our current trainees have absolutely no concept of that. And so, they think it's going backwards, but as we can see here that, the ability to master that this technique is actually, it forms a greater understanding of what is possible inside the eye. So I think that this organization is very important, and I'm really glad to be a part of it. And I hope that we can really add our younger trainees to understand the importance of mastering this technique.
Thank you so much. And when we're talking about larger incisions and the small incision cataract surgery, I probably would also get to your attention that the manual small incision, it's probably micro small incision cataract surgery by none other than Dr. Amulya Sahu, who makes 2 to 3 mm incisions, and he gets the nucleus out. That's the master actually performing. Unfortunately, we don't have his video for the today, but I'm sure in the future, we would definitely see his videos coming out over there. And definitely, Dr. Sahu, sir, do you want to comment anything on that?
Before he comments, I will say, we talk about large incision versus small incision, and I've actually pushed very hard among my trainees to call it manual versus phaco, simply because it's actually not the size of the incision. It's actually the technique itself that I think is more important that we understand.
Yeah, see, I think America should take to SICS, and then the world will look up to them. So I feel that it is no more a phaco or SICS. Either you are an artist. Why can't you be an artist? When you use your machine, you can use your hand also. There are wonderful surgeons, and the skill has been thrown into the winds when the phaco assault started. So it is time to balance it. You are all artists. You are so accomplished surgeons. Learning SICS will not take time. Just put your head down and see. You can create wonders. I'm doing a 2 mm SICS, and I think I'm going to go. So it's so easy and it's so good. Any steep axis anywhere, you can give your incision and get a wonderful result. So I think thanks that the chapter is getting formed, and people like you all committed people, and we'll take to the next level. So some of that, let there be a comparative study on the phaco and SICS results, so that many people will wake up and take it seriously. So we are offering ourselves to our skill, and let the best phaco surgeon and we compare our results, standardize it, and give it this thing. We will do it, and video we will send the results to you, and let somebody publish it.
Well, David Chang published that, didn't you? It's been published.
It's been a study done in Nepal about 10 years ago. Yeah, yes. There are editorials in the AJO on that. True.
And it was, it showed equivalency, and that was so. Part of this is we have to remember that there are more influences than just surgeons' opinions there in the United States, right? There's a lot of it's a corporation that there's a lot of way to make a lot of money out of phacoemulsification. So I mean say no more. I just want to take a moment to say to everyone, who really needs your help is Sub-Saharan Africa, because currently the training is it's good, but the sophistication of MICS is not there in the institutions. And residents are getting a limited amount of training, and then they're being put into situations of being 10 hours away from their mentors alone, cleaning up the backlog of these hard cases. And not having that skill set is it really is limiting their ability to build their own practice. And so I call on all of you to really, let's work together and bring this sophisticated technology to these countries.
I can see Dr. Maria Montero here, who has been teaching surgeons in Africa through the Flying Eye Hospital. So it's already been done by, so many different organizations. It needs to be done on a bigger scale.
Yes.
Yeah, on a larger scale.
Thank you, Dr. Susan. Thank you, Dr. Parikshit. We'll actually move forward with our next topic, multifocals in MSICS, a pilot study done by Dr. Jaime Martinez. I think now I got it right.
Excellent. Thank you, Dr. Jagadish. Yes, Dr. Jaime had to go offline. I want to apologize for him, but I'm going to be sharing the video from my computer. So I just want to say, even though we are able to have a lot of M6 cases in here, we're still learning. And we have now, seeing today's videos, we have a long way to go in our learning. So we're trying to move a little bit forward, and this is a pilot study that Dr. Macias and Dr. Omar Gonzalez are making, and they are implanting the first premium IOLs with M6. At least here in Mexico, it had never been done. So we want to share this video with you. Just a minute.
Hola a todos, buenos días. Es un gusto participar con ustedes en este webinar y saludar a todos desde acá de la Ciudad de México.
Can you hear it?
Yeah.
Ah, great. Thank you.
Muchas gracias. Bien, el día de hoy quiero compartir con ustedes esta pequeña charla que trata de cirugía de M6 con lentes intraoculares premium para presbicia. Sabemos que la técnica de M6 o Manual Small Incision Cataract Surgery es una excelente técnica que nos va a ofrecer buenos resultados refractivos y anatómicos similares a la cirugía de facomulsificación, con la gran ventaja que esta técnica puede prescindir de la tecnología. Hay algunas publicaciones muy conocidas por todos ustedes. Aquí vemos una de ellas donde tenemos un metaanálisis donde se revisan más de 76,800 ojos y en los cuales se compara la seguridad y eficacia de ambas técnicas y en las cuales no se encuentra una diferencia significativa entre los resultados de agudeza visual pre- y posoperatoria o agudeza visual con y sin corrección, así como la cantidad de pérdida celular endotelial, así como las complicaciones intra- y posoperatorias. Incluso el astigmatismo es muy similar y alguna de las ventajas que ha representado esta técnica es que se ocupa menos tiempo para hacer una cirugía de M6 comparada con la facomulsificación. Aquí hay alguna otra publicación donde también se compara la seguridad y eficacia entre las dos técnicas. Asimismo, también se refieren buenos resultados de ambas, con agudezas visuales muy buenas y un promedio de inducción a astigmatismo muy similar entre ambas técnicas. Entonces, ¿por qué hacer facomulsificación si las cirugías de M6 suele ser más segura, además de ser menos costosa? Bien, sabemos que en el mundo pues existe siempre alguna controversia sobre estas técnicas y los resultados que estas pueden ofrecer. Pero hay datos duros donde sí podemos ver que la técnica de MSICS es mucho más económica y muy accesible para los países que no cuentan con la posibilidad de tener una tecnología a la mano. Entonces es una técnica que es fácil de aprender y con resultados muy similares. Entonces esta pregunta queda en el aire. Hay que responderla de acuerdo a las condiciones en las que estemos trabajando cada uno de nosotros. Entonces la pregunta que nosotros nos hicimos es si esta técnica es tan segura y efectiva, ¿por qué no podemos implantar lentes premium? En este caso, lentes para presbicia. Nos dimos nosotros a la tarea de hacer un estudio inicial. Aquí les muestro algunas de las fotos que tenemos de un paciente a los 7 días después de la cirugía, donde vemos un lente perfectamente centrado y una cirugía donde vemos ya el proceso cicatrizal también con excelente evolución. Entonces, en este estudio llevamos apenas pocos pacientes, llevamos solamente 9 pacientes, en los criterios que utilizamos de inclusión son pacientes mayores de 50 años, con una catarata grado 4, un astigmatismo menor a 1,5 dioptrías. Utilizamos lentes de foco extendido específicamente para este estudio y evaluamos los datos demográficos de edad, sexo, así como la evaluación de las agudezas visuales cercana, intermedia y lejana. Aquí vemos los datos preoperatorios con las agudezas visuales promedio de 20/300 en las 3 visiones de ambas. Más o menos tuvimos en géneros 3 mujeres, 4 hombres con un promedio de edad de 66 años. Y aquí los resultados que nosotros tuvimos, bueno, la agudeza visual prequirúrgica fue de 20/320 en promedio y el resultado posoperatorio en promedio fue de 20/40. En cuanto a la agudeza visual intermedia, el resultado como les comentaba, fue de 20/320 y la agudeza visual postoperatoria en promedio fue de 20/40 en visión intermedia. En cuanto a visión cercana, la agudeza visual fue de 20/320 en el preoperatorio y de 20/100 en el postoperatorio. En cuanto al cilindro queratométrico, que es una parte muy controvertida, especialmente en este estudio, el resultados donde siempre resulta controversia cuando presentamos este tipo de tema, nosotros encontramos que sí había una mayor inducción de astigmatismo. El cambio queratométrico que nosotros observamos fue aproximadamente de 0.4 de inducción astigmática. Entonces, ¿qué podemos concluir nosotros con esta pequeña muestra de serie de casos? Nuestra agudeza visual lejana y cercana fueron buenas. La agudeza visual cercana no fue satisfactoria. Esto quizás sea debido a que el lente que utilizamos no está diseñado para ofrecer una excelente visión cercana y pudiéramos también tener un poco de sesgo en la parte del astigmatismo, que sí, ese cambio de 0.4 puede generar alteración en el resultado visual, sobre todo si tenemos en cuenta que el astigmatismo fuera mayor o ligeramente mayor a 1 dioptría. Entonces, la técnica quirúrgica de MSICS es segura y efectiva e incluso puede ser muy útil para implantar lentes premium en casos bien escogidos. Sin embargo, como les comentaba, habría que tomar en cuenta los cambios queratométricos a los que vamos a presentar, sobre todo con ese cambio de 0.4, que lo podríamos tomar en cuenta a nuestra conveniencia de acuerdo a la evaluación preoperatoria cuando se trate de un astigmatismo con o contra la regla. Y otro de los cambios que nosotros vamos a seguir haciendo en este estudio que seguimos corriendo va a ser considerar el uso de lentes trifocales. Esto pudiera darnos mejor resultado en la visión cercana. Bien, pues esto es lo que yo les quería compartir. Muchas gracias por su atención.
We cannot hear you, Dr. Jagadesh. You are on mute.
Yeah.
Thank you so much for that great presentation. And I'm pretty sure Dr. Sahu over there must be thinking multifocals on the Western Hemisphere, and that too in SICS. He must be really excited about it. And to remove that 0.4 diopter from your study, I think we can decrease it to 0.04 by those wonderful Dr. Boramani techniques, and I'm pretty sure it would be an amazing thing. Thank you so much for sharing. I would ask Dr. Miller to actually, and Dr. Sahu to actually make some comments.
The use of multifocal IOLs is, of course, a natural step in evolution for selection of lenses. At the present time, in the United States, we are reimbursed for spherical IOL corrections, but without proper reimbursement for providing toric correction. The situation I keep coming back to in my own mind is when I go to buy a pair of shoes. I walk in the store, I put my foot down, I find out how long my shoe is, but I also find out how wide my foot is. And when I buy a pair of shoes, I need both the length and the width. Why we are in a world where we buy lenses that are this long, but not necessarily this wide to correct for astigmatism remains a mystery to me. And I think that the next step of evolution in many of our practices will be to build toric correction in as a matter of course when necessary, and not have to charge a premium and reserve premium prices for the multifocal effect when the toric problem is managed. I certainly congratulate our colleagues in selecting patients appropriately for this initial study, because it's very clear that there are some patients that will be better managed with multifocal IOLs. For a multifocal IOL not to be a disappointment, it's clear that there are several factors that are important. The size of the pupil, the centration of the lens, but also the subject, the patient who is receiving that IOL, to be aware of what to expect, to be willing to go through the learning experience, to develop an appreciation for the change in their vision at different circumstances. So it seems as though the patient selection for this study was very well done, and I congratulate Jaime on this outcome. Thank you.
Thank you, Dr. Miller.
Thank you. Thank you so much, Dr. Miller. And Dr. Boramani, Dr. Boramani, do you want to add a few comments onto that, sir?
Yeah, always see, it is presumed that the multifocals and SICS, they don't go hand in hand because of the higher induced astigmatism. But if one learns how to neutralize or correct the astigmatism with my methodology, then perhaps we'll put multifocal with more and more confidence. Means more confidence than a phacosurgeon also, because then you are sure how much your end astigmatism will be there, and you will put a multifocal. And I have briefly mentioned about new IOL, multifocal IOL introduced in India. This is designed by Indian surgeons. In fact, it's a monofocal lens, but it works better than multifocal because there are no rings, so there are no glare, halo, no positive or negative dysphotopsia. The technology is that the very centralmost part of the lens is of a higher refractive index, same hydrophobic acrylic material, central part having higher refractive index than the peripheral part. So it works like a progressive lens. It's a radial progressive lens. And this lens design is not a circular one. It is 6 mm by 7 mm. So it has to be placed horizontally. So many times you can see a ring, crescentic scotoma because of the peripheral spherical aberrations in the temporal aspect of the field. So that also is taken care if this lens is put horizontally oval. So I think this is a fantastic development, and mostly these lenses will become popular, and the multinational companies also will start manufacturing this lens. It's a fantastic lens. Thank you.
Thank you, sir. Thank you for the input. It was all a wonderful talk. And next, we would go in the discussion part about teaching and practicing of M6 and its importance. The moderator, I would hand it over to the moderators, Dr. Pamela Gonzalez, and who is the president of the Mexico chapter, and our vice chairman, ISMS, Dr. Parikshit Gulati.
Thank you.
Over to you, sir.
Thank you, Dr. Jagdish. I think, Dr. Pamela, you are the main host, so if you can start the moderation.
Thank you, Dr. Parikshit. So it's been a really, really nice webinar. So this is the interesting part where we all live in different countries. We all experience different scenarios every day for teaching and for attending our patients. So we are all phaco surgeons and we are all M6 surgeons. And I'm sure we are not fighting each of the techniques. we all recognize the benefit and the good things of both techniques, and that we have scenarios where phaco is going to be our very best choice, but we also have scenarios where M6 is going to be the best choice, no doubt. So I would like to hear from all our panelists, maybe a few words saying, what about M6? How do you find it useful and special situation? I think any comment would you like to make about M6 or any doubt, I think would be great. So if everyone is okay with this, we can start with our US panelists. So Dr. Lisa Park, I would like to hear your comments, your thoughts, or whatever you want to share with us about this.
Thank you. Yep, I think this clearly is an important aspect of, teaching, the concept of, no matter what technique that you use to safely remove the lens from the eye. And I think that that is something that concept in and of itself, that one technique is not necessarily superior or inferior to the other, but using a variety of techniques to approach the particular situation at hand is the most important concept to transmit. In places where, and we can even see it in New York City, where there's a cataract surgeon. You throw a stone and you'll hit a cataract surgeon, and so because of that, our patient population has access to so many different, possibilities. And so I think that in our particular institution, our focus is on transmitting the best technique for the particular patient in the patient population. And so there are many issues that are involved with that, certain expectations. There, of course, is, the financial aspect of, such, different techniques. But I think that it is very important to emphasize that, regardless of all those other factors, that it is matching the technique to the particular clinical situation, which I think is the most critical. So that being said, in New York, sometimes it's hard to find those cases that, where the advantage will be to, teach for somebody who's not well equipped yet, those manual techniques. And I think that is the challenge. And for that reason, I try to bring fellows and residents with me when I go to places where I think that they'll have a higher volume of being able to see those particular types of patients. And so that is my interest in global health. It's not only to, help those that we can help, those who financially would not be able to get phacoemulsification, let's just say, but also too, for the sake of transmitting this knowledge to our trainees so that they have the wide range of, strategies under their belt and can feel comfortable in any particular clinical situation. So I think that is the challenge in training.
Lisa,
you put it well, that you have to match the patient's expectations with the technique. And I think that is the key to it. Yeah.
Lisa, can I ask you one question?
Yes.
This will be asked to everybody here. How you want to take it forward, this training program, MSICS, in USA? What are the limitations? What are the restrictions? How we can take it further? And where we can play a role in that?
So I think actually one of the main limitations is actually having enough trainers, having enough teachers that are comfortable enough with the technique. So, in my institution, literally I get all of those cases simply because there's the faculty, don't, many of the current, practicing cataract surgeons, they're primarily doing phaco all the time. And so in order to teach, you have to have that that skill set. So actually, I think that it's a combination of providing the excellent courses and teaching that you already have for the educators, actually, so that that then on a regular basis then to teach the younger trainees that we're operating with all the time. So I think that's the first aspect. And the second aspect is opportunity, providing the opportunity for people who desire that to train with some of you who clearly have, the expertise and such a wealth of knowledge. And if we can do that side by side, we talk a lot about simulation, we talk a lot about, virtual training, etc. But really the bottom line becomes making, decision making in real time next to those who have that expertise. Actually, I really think that's actually the best way.
Sure. I think we should also ask Dr. Jayashree Barua. Dr. Jayashree is a teacher in a medical college from Assam. That's one of the eastern parts of India, a relatively less developed part of India. And she teaches in a public hospital, a government medical college, as we would put it in India. So what are your take on this, Dr. Jayashree? Please unmute yourself, Dr. Jayashree. We can't hear you. Unmute yourself.
Yeah, so sorry. Am I audible now?
Yes, we can hear you.
Yeah, actually, thank you so much for making me a part of this wonderful webinar today. Now, my take is on SICS. SICS is like you have a tool in your toolbox, which we don't require every day. But one day you may end up realizing that this is the most important tool in your toolbox. So it's very important that you keep this tool handy, because no doubt today's younger generation of trainees, they have access to the best of the FECO machines. Even they have access to the femtosecond laser surgeries today. But all said and done, what we see in conferences, what we see in the YouTube videos are the best of the surgical techniques, are the best of the management techniques. But what Dr. Boni has showed us today, that is the real scenario. So we need to, as trainees, we need to teach our trainees, the residents, to learn how to tackle any sort of problem, any type of cataract in any situation. So SICS is a must tool in our toolbox. Thank you.
Doctor, but for your residents, do you teach both manual SICS and FECO, or how do you go about doing it in Assam?
For me personally, it is at least 2 cases of extracapsular cataract surgery. Because why this? Because this is the only point where where our residents they can learn the suturing technique. Because you skip the ECC part, you don't get to learn about the orientation of the anterior chamber of the eye, and you don't get to learn your suturing techniques. So I prefer at least 2 or 3 cases of extracapsular first, followed by the small incision cataract surgery, and then teaching you the FECO surgery, because what in most of the steps they are similar. And once you're well versed with the SICS step, the flow from the transit from SICS to FECO becomes very easy.
Great. So I believe that even conventional extracapsular cataract extraction does have a small role to play, especially if the corneas are not at all good. I mean, of course, what we have seen, Dr. Ravindra or Dr. Boramani, they are like awesome. But then there are cases, and we do see very, very black cataracts, very senior citizens, 95, 100-year-old with, corneas that are not good. Yes, so in them, the larger incision is better. So I'm so glad that there are still medical programs which are teaching conventional extracap, at least some part of it.
Dr. Boni, I think you have a comment, and Dr. Susan also.
Yes. So a few years ago, we did a survey of the residency programs in the United States, and we surveyed the residency directors and the chairman and asked them whether they see a role for manual cataract surgery and whether they think it's important, should we teach it? And we also asked how many programs around the country actually still taught manual cataract surgery besides FECO. And what was interesting was when we received the results, I would say about 90% of the residency directors and the chairman believed that it was important to teach manual cataract surgeries. They said that there was definitely a role, it was very important, and they believed it was crucial for the education of the future doctors. When we asked how many programs actually teach it, it was about 5% of the programs. And that's actually even less now than it was several years ago. And so we published that data, and what that led us to believe is there is a demand. We think it's important. And the problem, exactly what Lisa Park said, was the main issue is that we don't have enough teachers to teach the manual surgery. So I think to answer, Dr. Gonzalez's question, Dr. Sahu's question about what do we do to move this forward, is I think we need organizations like ISMSICS to actually come to countries like the US to actually show teachers how to teach. And the way to do that is either to do it at national meetings like the AAO, ASCRS. There is a academic meeting for the Association of University Professors called AUPO, and to actually bring in the teachers to teach those people. There's a session called Educate the Educators. And that's a perfect venue to teach something like this and to show the results, the studies that you've already highlighted that show that manual surgery is not inferior to phaco, and that even astigmatism can be well controlled. So that message has to get out there. It's not currently well known in the US that manual surgery is possible and that it actually has such minimal side effects than phaco. So if we can get that to the national and international meetings, I think that would be helpful.
Wonderful. Yeah, that's wonderful. Yeah.
Dr. Susan, you wanted to comment also.
I just wanted to say, Dr. Sao and everyone on this webinar right now, you're doing exactly what we need. And but I just want to give you the perspective of let's take Bonnie's lecture and then we're talking about learning, postgraduate learning of these educators, and then we're still on a learning curve. And then I've become a very good SICS surgeon, but I was trained as a phaco surgeon. I only did 2 extra caps, and then the rest of my training was phaco. And I spent 25 years teaching phaco. And then you just imagine, when do I choose to do SICS? I choose the case that's the hardest case that I don't want to do phaco on, because in my toolbox, SICS is an inferior tool. And so what I needed to do is get the experience behind me to actually have it be an equivalent tool. And that takes a commitment by the surgeon. So if you don't have that equivalence, you bring in your resident and you're trying to teach your resident, and the resident witnesses a nightmare. And what does the resident think? The resident's like, I am never going to try that. I don't want to repeat that. And so part of it is really getting our surgeons not to just be familiar with the technology, but to become efficient with it. And so I absolutely agree with Bonnie that people like Bonnie, people like Lisa, and need to get on that podium and start talking about the fact that if you're not, I mean, Bonnie will have to use her magical softening technique of this message I'm going to say, right? We need to tweak this. But if you don't have the skill set of SICS and being a really superb SICS surgeon, you're not really offering your patient every technique that they deserve. So Bonnie, if you could just make that really, tone it down a little bit, I think that would be what we need to say, is we really need to speak out and really, because we are competing with companies and corporations that really have the market share. And I think if we don't look at it as exactly that, it's a market share that we're talking about. And it's business, man.
I mean, Susan, you're right. I mean, the elephant in the room is industry. And the elephant is that, there are companies that need to survive by selling fecal emulsification instrumentation. So, maybe somehow we can all brainstorm together to find out how we can partner with the industry companies so that they have a way to make a business out of this as well. So they can survive, they can make a profit, but yet we're delivering really good, inexpensive care to the patients around the world that really need it. So I'll leave it to, Dr. Sahu and Dr. Boramani to brainstorm how we can get the companies to make a profit on SICS, and then they will help make the movement go forward.
I think when multifocals will be used with SICS, so that's the time when the makers of Restore and Techness and Hoya will all also think of that. Yeah.
Can I come in, Parikshit?
Yes, sir.
See, you have to learn from India. Then all companies are prospering. Nobody has lost anything here, and we are doing SICS. We are using their high-end lenses, and frequently all SICS surgeons, if they start using high-end lenses, where is the loss? Except the machine selling, and they are making a lot of profit. We are doing and everything else. So once they are assured that business is not going to be lost, in India they are surviving. So there is same module can be taken into America. Only thing, the good teachers now come out. Teacher like Boni and to now become the best SICS surgeon, and then there will be line up. And similarly, all these bright stars, they have to adopt SICS, and then the followers will not have any doubt. So to instill confidence in them, as Boni said, that a teacher's training should start. And let us develop a mechanism of training SICS surgeons.
Yes, Dr. Pamela. And then we can take a comment from Dr. Satanshu also.
Dr. Miller also want to say something. Dr. Miller wants to add.
Yes, of course. I just wanted to ask Dr. Maria Montero, who is in the Orbis Flying Eye Hospital, to have her comment, because I would love to hear from her how they work in spreading the teaching of M6, because as Dr. Bonnie and Dr. Susan said, well, sometimes it's that surgeons, it's not that they don't want to practice, it's they don't have where or someone to teach them or to help them get better with the technique.
Yes, thank you, Pamela. So first, I wanted to share with you our web page where we have courses specifically for manual small incision cataract surgery. And so we've been using this course mixed with live lectures, and even we piloted a remote virtual simulation course in manual small incision cataract surgery with Dr. Parikshit just a couple of months ago, which was very nice, and I thought that we had great outcomes. And also with Pamela, we held a virtual course on manual small incision cataract surgery. So we've been trying to come up with new ways of teaching this method and having everybody around the world have it in their toolbox, like we were saying before.
You know what? I think having a webinar for all of the U.S. Residents would be an amazing step forward. And I think residents want to learn this. You know, they really want to learn.
Maria has a technique by which they can learn it, even, I mean, from a distance.
Right. Yeah, I just think, you know, and you can't sit through the lectures we had this morning and not want this. But it really is a paradigm shift for the United States to actually believe that those techniques are actually we're capable of doing that, because that is not, like Bonnie said, that is not the impression that the average US surgeon feels, that they are providing the superior technique right now, which is fecal emulsification in their mind.
Dr. Miller, you wanted to say something?
Yes, I think that it's not proper to malign the manufacturers in this situation. The reason M6 is not popular in the United States to the extent that it is elsewhere in the world, I think also reflects the patient population. I've been in countries in Africa where the best vision of the day was 2200, and the majority of the lenses were rock hard. Whereas in Central America, we see closer to what we see in the United States with a mix of 2060 to 2200 cataracts. But in the United States, if you were to walk around Manhattan, I would imagine that even though it's New York, they're what's called California cataracts, and I'm not certain that those things are appropriate for M6. So we have to accept the fact, first of all, that the demographics of the average patient that is being seen is better suited to one technology than another, all other things being equal. The second is, the reason I don't think it's malign the manufacturers is because they have become wonderfully adept at delivering the very best possible care that is available at the reimbursement point paid for by the federal government in the United States for cataract surgery. That we have a system that is optimized to deliver care at a given price point, which is that provided by the government for reimbursement. There is no price advantage in the United States to provide M6. If there is a savings, it is very difficult to achieve because at this point, the cost of our pharmaceuticals has risen so high that the relative cost advantage of M6 is completely overshadowed by the price of all the other pharmacologic agents that are used during surgery. We do not have a price advantage that is often achievable. So for both these reasons, I think it's going to be an uphill problem to train individuals in M6. And with that, I would just ask that for some of the folks that are at the younger end of the curve who have only done phacoemulsification surgery as their entire training program, which is certainly what we have been doing at the University of Arizona for at least 15 years. We somewhere around 20 years ago quit requiring 20 extra caps, maybe 25 years ago. And now I imagine that we have residents graduating who have done perhaps 3 extra caps, 2 extra caps, or seen 1, because the pressurized eye that is being done with phacoemulsification for soft lenses is perhaps the better surgery to be doing. With that, I open it to comments, but with a challenge to explain to me what the economic advantage is of M6 if the price point is the same either way. We cannot offer patients money in their pocket by having a less expensive surgery performed.
So
Bonnie, you had wanted to.
Sorry, I was just gonna say that, Joe, excellent points. I completely agree with you, and it's not fair to speak ill of the industry partners. They've actually been quite good about trying to deliver the best they can. I do think that in the U.S. it's a very different situation, like you highlighted. I think the financial benefit is very different because everybody is really covered, whether it's through Medicaid or health insurance, or even programs within the domestic part of the U.S. through something like ASCRS. People can have phacoemulsification for free. So there is no real cost benefit to the patient, whether they have one particular technique or the other. And you're absolutely right. I think the point was really that other people were saying that the actual benefit is really to teach people how to do it, just because cases do come across where it is a benefit, may not be the norm, but every once in a while, surgeons who were trained in extra cap surgery at least know how to manipulate the sclera and make an incision. And now these younger residents, they barely have any techniques on how to deal with the sclera. They really don't understand how to manipulate those tissues because they don't cut into it very often. So it would be wonderful to find some way to teach these youngsters how to do this when they don't need it all that often. So I agree with your points.
I have a colleague that's an extremely skilled cornea surgeon who does corneal transplants and who went out on a limb and video recorded an M6 case for the purposes of showing our residents. It was an appropriate case. It was a very hard nucleus, and to see how the gentleman struggled with the wound construction because it's a complicated wound. To see how the gentleman struggled with chipping the nucleus up into the AC, it made me feel a great deal of empathy for the situation. But here's an extremely skilled cornea surgeon who only rarely has the opportunity to perform an M6. And if you're a very accomplished cornea and cataract surgeon, and the opportunity arises twice a year, it's going to be very hard for us to develop the expertise to convince the residents it's a safe and easy procedure to do when it's appropriate.
If I could have the opportunity to respond, I actually can't. I appreciate your comments, Joe. On the other hand, our educational forums are supported, and our educational societies are supported by our dues, but also by industry. And I think and how we practice also is an economically driven, which is also our government and the insurance companies. So I think there's plenty of influences, but I do believe that pushing phacoemulsification as a technology has had several people have been involved in that, and there's been a financial benefit from that. And I think us as leaders, we just need to keep in mind, keep sharing information and learning from the international community that, maybe we don't have the only or the best solution. And having become a very good SICS surgeon, I changed my choice because I finally had that skill set and offered it to my patients when they needed it. And you know what? They did better. And I have to, I made choices to do phaco when I really probably should have done SICS earlier in my career, but I did not have that skill set. And it only was working with Alan Crandall and going and doing, spending many hours and many days, many months doing international work that became my go-to for difficult cases where I was better at that than at phaco. And so, I appreciate, I don't want to say anything negative about these companies because they provide a lot of educational opportunities for us. But I also think we need to be part of the conversation of how we go forward in the United States. And that's been hard for us to sit at that table because we have, I think corporations have led that charge.
That's a very candid confession. And I think, yes, we need to engage all kinds of techniques. Thank you, Dr. Susan, for bringing that up. And as Dr. Miller said, even like when I started my training in 1990s, I trained first in intracap, then extracap, and then phacoemulsification, and then manual small incision cataract surgery. So I think like Dr. Ravindran or Dr. Sahu, we learned phaco first, and then we learned manual SICS a large way. Dr. Jagdish wants to make a comment, and as does Dr. Satanshu, who is from the northern state of India. So we'll just take two comments from them, one from Dr. Maria again, because she does a lot of work in Africa, and then perhaps we can start wrapping up the meeting.
I think the bureaucracy of all these medical companies aside, and there also is a place where the licensing system of the United States does not allow external doctors to actually come inside the country and teach something like this. So there should be some kind of a global platform which actually would help young ophthalmologists to actually venture out a skill which is very essential. It's not about the money or the benefit which the patient gets, but I would definitely say there are instances where an SICS surgery is superior to a phaco surgery, and definitely the money is not the aspect over there where you want to give a better outcome for the patient. Even in terms of an astigmatism, probably as showed by, I know it requires a lot of skill, but to do phaco too, there requires an amount of skill. SICS requires even lot more skill. So why do we have to price less? I'm not talking about the money aspect. Keeping aside the money aspect, if you want to do it less, yes, you could do it less. Maybe for all those countries out there which cannot afford it. But for the United States, I don't think so. You have to be pricing it less to add an advantage onto the patient, but probably delivering a skill to your young residents where they can come out of situations where it's more easier for them when a phaco gets complicated. If they can actually know M6, they can easily come out of the situation rather than approaching a retinal surgeon, and which would drastically increase the cost again on the insurance. Probably, this is my take on it. I do agree there are some instances where the medical companies do help. But if our organization as ophthalmologists want to venture out and promote M6, I think no medical company would be interested in promoting the other way around. I think it's also lies on us to an extent. I think phaco is a skill which is easily gained rather than SICS, and we try to learn it at a faster rate. And you think that as a bloodless surgery and stuff, and then go on. But later on, I think if you are good at M6, you can still actually have a very elegant surgery. I've seen those excellent videos all from those people, excellent videos out there, which is nowhere less or even in fact more compared to the phaco. That's probably my take on it.
Yeah, but then speaking with the insurance companies and the governments is something that takes a very long time, and it's labyrinthine. It may take years, decades perhaps, for that policy change to occur. But yes, you suggested a good way. Dr. Satanshu.
Thank you, Parikshit. In my opinion, every cataract surgeon should be a comprehensive cataract surgeon. When he goes to the operation theater, he should be armed with all techniques of cataract surgery available in the earth, on the earth. He does not know which technique will bail him out in difficult cases. In countries like India and other like countries, hard cataract and hardest cataracts are very easy to find out daily routine practice. And every cataract surgeon in small city is not armed with the advanced phaco machine, and you have to use high-end viscoelastic, so costly surgery become costly. So, my opinion, everybody should learn that even the expert phaco surgeon might need sometime SICS surgery or extracapsular surgery. They are doing it. So we should encourage all types of surgeries, and we should learn each type of surgeries. In medical college in India, SICS taught first, and then come the phaco. If they do few cases of SICS, only then they are taught the phaco. So that point has changed now. In your time, it might be phaco first because SICS was not so popular. But nowadays, SICS becomes so popular in India, and many of doctors in the medical college are doing it. So students are taught SICS first, then come the phaco. As far as companies are concerned, in India, scenario is different, in my opinion. Dr. Parikshit, Dr. Saub, Dr. Boramani will agree. We are organizing international conferences every alternate year, and we are finding good sponsors. So in India, sponsorship sometimes depends upon face of the person who is organizing it. Number one, if I go and ask for the money, they will give, whether I do SICS, I will do that on mine. But definitely, if we start as India, we have started doing multifocals in SICS. So as Dr. Saub and Dr. Parikshit told, it is definitely going to be popular among the commercial people also, because if multifocal, trifocals are using, we are doing it regularly nowadays. So India is scenario different. As for teaching is concerned, we are teaching, I am especially teaching the students the SICS surgery on animal eye, and then with the help of simulation that is available now with the help of LPC, Dr. Sahu has got a lot for it. This is very good teaching instrument and easy to learn by anyone, by students, by teachers. So this techniques, if we apply in our practice, in our medical colleges, this is definitely going to help us. As for teachers are concerned, in India, there are a lot of teachers. If anybody needed help, Dr. Sahu will arrange lot of teachers, I believe it. They can go and teach anybody. We can teach on the by the internet also. So this technique is really definitely very good. And we should, each and everyone should learn this technique, whether we use it daily practice or does not. Thank you, Prakshit.
Thank you, Dr. Satanshu. Dr. Maria, would you like to, because you've done so much international work, I mean, truly global in the sense across continents. So if you can quickly sum up and, give your inputs.
Thank you. Yes, I would like to say that everybody should have this tool, but of course there are countries that are in greater need of this tool because they don't have insurance or the insurance doesn't cover ophthalmology at all. So of course, in those countries, there's a greater need for it. We've been working in Cameroon, Ghana, Zambia, Ethiopia, in Peru, teaching small incision cataract surgery, because I think that people will choose the technique only if they know how to do it, because it's a very difficult thing to pick this technique. And if you don't know how to do it yourself, send it over to a colleague who knows how to do this technique. It would take a very humble surgeon to do this. Just yesterday, I saw a publication in a Facebook page that's called International Ophthalmology, and doctors sent over a photograph of a Negron's cataract. And the surgeon asked, what technique would you do? And out of 94 answers, 43 people said extra cap, and 42 said small incision, 3 said phaco, and 6 said whatever you can do with your own hands, whatever your technique is. And I find this very, it's very clear that the people that say extra cap is because that's what they know, and they're not wrong. If they don't have access to, or they don't know how to do small incision, and they're the only person there, of course, whatever your hands can do. And if you can do small incision, if you know how to do small incision, you would never say extra cap in my eyes. But that's the thing. If you don't know how to do it, it's very difficult to send over to a colleague who knows how to.
Thank you. Thank you, Dr. Maria. Dr. Ravindran, sir, Dr. Pamela.
Yes, this is a really, really interesting discussion. And as we all agree, our main concern is our patients safe. We are all in different parts of the world. We all have access to different technology, to different kind of insurance coverage. So M6, for those who, like in Mexico, a lot of our patients have access to phaco. So we do have access to phaco, and it's a phaco case, okay, go and do a great phaco. I just love it because I have excellent predictable results. But if it is a really, really hard cataract and I feel comfortable with M6, okay, go ahead and do it with M6. But I think the best saying of the day, as Dr. Maria and almost all of us have said, and as Dr. Susan said, is, okay, go ahead and do what you feel comfortable with because you're the surgeon. So you're going to be in charge of your patient results. But of course, knowing different techniques, it's always making your bag of tools as a surgeon better. So this has been a great discussion. And if Dr. Parishit agrees, I think we're ready for a final comment for each one of us.
Yeah, Dr. Ravindran.
Yeah, I think it was a unique discussion. What I would like to say is, apart from the economics, the skills of the surgeon. So of course, phacoemulsification is a great equalizer. I know if there are surgeons of different skills, it equalizes everybody. Everybody can do a very good phaco. But if it comes to SICS, there will be a difference between a skilled surgeon and the person who would like to spend more time developing his skills. So that's the reason why phaco is very popular. In India, where we do both phacoemulsification as well as SICS, we divide the patients not only on economic reasons, but also indications. Like, for example, in our hospital, when a posterior polar cataract comes, we will no way will go on phacoemulsification. We'll straight away go into a very simple technique. I demonstrated one of them. Extremely, I've never broken a posterior capsule with hydrodissection in a posterior polar cataract. So evidently, the mature cataract, a brown cataract, SICS comes in hand. So we have not only the economic reason, we don't charge them separately. The prices are same for whether you do SICS or emulsification. The second thing that I've seen in all these hospitals is in United States and developing countries, you are very meticulous with asepsis. I mean, you throw away all these disposables, but in India, for economic reasons, we tend to reuse them. They become blunt, or in many scenarios, like, we reuse it even without proper sterilization. So this dilution of the, the asepsis is one reason why I shifted completely.
Not anymore, I think.
Not anymore. So
we go to jail if we do that.
So I found that it's much safer in terms of the endophthalmitis or the TARS, the percentages postoperatively. I don't use moxiflox at the end of surgery. We don't have infections. So that's one point, not only the economics, but in scenarios where you have more patients and a very limited amount of funding, I mean, you can serve with SICS more number of patients as against, the quality or whatever you call it. So choosing the right technique for the right patient and the right eye is probably possible when every surgeon has suggested again, masters both techniques. There's nothing like inferior, superior. For one presentation, it has to be the best is what you have. Armamentarium should be complete. That's what I feel. I would like to ask Dr. Susan whether doing an SICS is an offense in America. Can you be sued because you didn't do a phaco and you did an SICS? Is there a scenario, legal scenario like that?
Let me, I just want to make sure no, it's all about outcome, right? If you have a bad complication, if you do a bad surgery, you have an opportunity to be sued, but if you have a good outcome, that's not it. So I don't think you can be sued.
Bad outcomes can come either in phaco or SICS, but imagine there is a bad outcome and can the surgeon be sued because you didn't choose to do a phaco and you chose to do an SICS? This is a theoretical question.
Okay, so let's just step back and understand that our legal system is not one of that is absolutely right and wrong. We also, if you go to court, you have a jury, so you would have an attorney that could possibly get several expert witnesses that would say it's an inferior procedure. But you could also, and if my skill, this is a good question, because if I'm doing, 500 phacos and only 2 SICSs a year, then the question becomes, was I doing my best technique? So it's a complicated, it's a simple answer, no, but it's a complicated issue because, unless that I'm very good at SICS, I probably shouldn't be doing it because it's not equivalent. My techniques aren't equivalent. Like Pamela was saying, you need to do what's best in your hands. And the problem is what we're talking about is how do we get surgeons to be as accomplished as the individual speakers today and yourself, sir? I mean, if I was as talented as you, let them sue me, because I would be doing these amazing, I could prove to people that this was the superior technology, is my point. It's, and I have to say attorneys can manipulate if you go in the literature in the US, people do have a sense that it is an inferior technique. That I'm sorry to say that out loud, but I think that's the truth.
Oh, thank you. So can we hand this over to Dr. Jagdish for a thank you, or would anybody else would want to say something?
I
I
was
think
just
Dr. Lisa has a final comment.
No, I think that Susan brings up such a good point, and that is, and we've talked about the best technique in the best clinical situation. We also have to acknowledge, and this has come up recently, especially with this COVID pandemic, actually, it's healthcare disparities among various groups of people. In the United States, we have such a diverse population, and it has become very clear that, the way the healthcare is delivered is different among different segments of our population. And so this also becomes a little bit tricky, because who is it that comes to us with the very, very dense cataracts and, those that probably would benefit the most from manual technique? It is often those people who do not have access to healthcare. And so then to put that in combination with this perception that this is maybe not a advanced technique, or somehow this is inferior or something like that, becomes a little bit tricky. And so I do think our responsibility is to become the best possible surgeons under all sorts of circumstances, utilizing all these techniques in order to then address this issue. So I think that the concept of educating the educators and really pushing forward this amongst the best surgeons in the United States and in elsewhere, is probably the starting point.
Thank you very much. So we will go with the wrap up and final comments. Dr. Joe, final comment.
I think I said too much already.
Well, thanks for giving here. Dr. Jillian Wang, final comment.
Yeah, I just want to thank everyone for being such an inspiration. I mean, I was first introduced as a medical student watching Dr. Sanduk Ruit doing a bunch of manual small incision surgeries. And so when I started residency, I really wanted to learn, but unfortunately I only got 2 cases and didn't really have a true mentor. And so I was very, very privileged to work with Dr. Pamela in Mexico and get a couple more cases and learn some techniques. And I actually really liked that training process. And I'm hoping to copy that and do that with my residents here at the University of Arizona, and at least get them comfortable, as many have said, working with the conj and the sclera to make that tunneled incision, which we just really don't do. So thank you, everyone.
Thank you. Dr. Bunny, final comment.
Thank you.
So I just wanted to say thanks to everybody, and thanks to Dr. Pamela for reining us all in, and thank you for all the organizers to put this together. I mean, it's such an important topic, as you can tell, and it's so interesting to hear about all the different side topics, not just the actual surgical procedure itself. So I look forward to meeting again, hopefully in person sometime, and hopefully we'll be able to spread the message and train our fellow colleagues.
Thank you. Dr. Jagadesh, final comment.
Thank you. And thank you so much for everyone for taking their valuable time. Especially thanks for all the office bear, the core members, Dr. Amulya Sahu sir, Dr. Boramani, Dr. Parikshit Cook, Dr. Satanshu, Dr. Bhattacharya, and Dr. Srinivas Joshi sir. Thank you so much for being here. And without you, this would not be a possibility. And I'm pretty sure our 2 new chapter installations for today would go a long way for us. And special thanks in the Mexican chapter to Dr. Pamela. And it's noteworthy to actually add Dr. Amy Martinez and Dr. Teresa Flores. Actually, thank you for being a part of it. And I also thank Dr. Sandra Cruz and Dr. Omar and Dr. Sandra Cardenas. Thank you for being a part of this Mexican chapter. And also the scientific committee members, Dr. Fabilo, Dr. Iliana, the executive members, Dr. Eder and Dr. Maria Jose. And coming to the US chapter, thank you, Dr. Miller. It's really a privilege to have you on board as a chairman, and Dr. Wang for being a vice chairman, and Dr. Henderson, who has always been with the M6 community for a long time. Thank you. And to go ahead, Dr. Lisa, Dr. Jeff, and Dr. Sarah, thank you for being a part of the community again. And along with this, I would special thanks to Dr. Susan, Dr. Ravindra sir, and Dr. Jayashri Baru. Thank you for being there today and making this a memorable occasion on this chapter installation of United States and Mexico. Thank you, everyone, and but not the least, for all these technical things to happen, the whole of entire family. Thank you so much for making it happen. Thank you again, everyone.
And thanks to Entored for giving us the platform, Mr. Raman, Mr. Rahul, and Mr. Rohit.
Thank you everyone for being here.
Thank you, and have a good day.
Bye.
Thank you. Have a good day. Bye.
Bye-bye.
Yeah.
Bye.
Bye.
Bye. Thank you.